Assalamu alaikum wa rahmatullah. Welcome everyone to our webinar on patient safety in healthcare facilities. So the first topic that we will be discussing today is the ABC of patient safety. First of all, what is patient safety? It is the reduction and the mitigation of an unsafe act within the healthcare system or facility, as well as through the use of best practice that has been shown to lead to the optimal patient outcomes and impact on the patient life. So there are some guidelines that we need to follow in order to improve the patient safety. And one of these guidelines is to follow the serial guidelines about asking us to communicate among the team members to enhance the patient outcome using the exchange of information, and to also listen to the patient or the family member when they are complaining, which is an obligation to assess the relevance of all the information and not to dismiss any information the patient is trying to tell us. We should also look closely at the patient, and not just the monitors or the equipment and devices, but to look to the patient to see if they are pale or they are at discomfort or at pain. So the first step that we need to take to ensure the patient safety is to review the client files and documents, then to talk to and listen to the individual patient and interview them about the patient and staff group discussions. We should then observe with direct observation and also for any signs or symptoms as we mentioned. After that, we need to record what is being read, heard, and seen from the patient. There is also some guidelines which are the required organizational practice. This is defined as an essential practice that the organizations must have in place in order to enhance the patient safety and minimize any risk that the patient can experience. In regard to the first column that we have discussed, which is the patient safety area in regard to communication, this required an organizational practice with using information and educating the patient or their families about their roles in the patient safety using both a written and the verbal communication. While the required organizational practice can also employ an effective mechanisms for transfer of information at an interface point, including the shift change, the discharge, and also the patient movement between the healthcare services and even between wards, and to implement improvement as needed. While the second point, which is reviewing the patient data and files, this has a variety of meaning when regarded to the patient safety, as the serial guidelines ask us to communicate among the team members, to listen to the patient or the family member, and to look at the patient closely. And for the frameworks, we need to have accreditations that are the required organizational practice and legalization that the patient needs. There is also another strategy to ensure the patient safety, which is the change management strategies, including goal setting of the SMART goal. The SMART goal is an abbreviation for specific, measurable, attainable, realistic, and timely goals or objectives that we need to achieve. In regard to the first point, which is specific, we need to emphasize what we want to happen to the patient and regarding to the care, and address the following questions. who is involved in the patient care, what do we want to accomplish by implementing this specific treatment or intervention, and where will the activity take place, in which ward, for example, or in an outpatient setting. And also we need to address why will this activity improve the patient safety. For the second point, which is a measurable outcome, this includes keeping us as a health practitioner on track and establish a target that we can measure and provide motivation when the targets are met with quantifying the outcome. For example, for the first point, a specific goal is I want the patient to lose weight, while a measurable goal would be I want the patient to lose 20 pounds. For the third point, which is attainable, we need to assess if this goal or specific objective is achievable. Can we do it as healthcare practitioner? Even if it was in small steps, which can represent small wins. And also to set our team up for success by making a goal within reach, not like a higher goal that is the end goal. We need to have small measurable goals. Also, the capitalization of the synergy of an interprofessional team to ensure that all aspects of the goal are being considered. The third point, which is a goal must be realistic. This is striking a balance between what we want to accomplish and also the resources or environment that are currently available to help achieve your goal. This will depend, of course, on the facilities within the healthcare facility. And for the last goal or setting is a timely goal, which can be established on an endpoint to the activity, for example, within a month or within 6 months. Also, it can help create a sense of urgency. For example, as we said previously, I want the patient to lose weight. A specific goal would be I want the patient, or a measurable goal would be I want the patient to lose 20 pounds. And a timely goal would be I want the patient to lose 20 pounds by November, for example. So the improvement model or framework of enhancing any healthcare facility patient outcome is to first act. The first step is to plan, which includes setting objective using the SMART goal that we just described. Also to set questions and prediction as what will happen and why. To plan to carry out the cycles of who will be the beneficiary of the plan, what will the action be, and where will it be implemented and when. The second is to do, which is to carry out the plan, to document the problems and the unexpected observation that we encounter, and also to begin the analysis of the data. The third step is to study or review with complete analysis of the data, comparing the data to the predictions, and to summarize what was learned. And the fourth step is to act or to implement what modifications are to be made, and including how to implement the next cycle. So this is an ongoing process that can improve the patient safety within any healthcare facility. So after discussing briefly the plans or the strategies that we can take to ensure the patient safety, we will now continue discussing the quality improvement for patient safety. So to enhance the quality improvement models and theories such as the BDCA can be implemented. And also quality can be improved by collecting and managing the stakeholder feedbacks regarding the services that was presented to the patients, and to also assess the differences between the quality assurance, the management control, and also the improvement. And the last step in quality improvement is the evaluation and measuring of the impact of any plan that was interpreted or implemented to the patient to ensure that we deliver the best care level of care to any patient in a healthcare facility. So, the patient safety is the avoidance of any unintended or unexpected harm to people or patients during the provision of healthcare. While the quality improvement is the combined and unceasing effort of everyone in the healthcare facility to make the changes that will lead to a better patient outcome in regard to their health and a better system performance in regard to the care that is being delivered, and also a better professional development, including learning from the service that we presented to the patient. So quality care depends mainly on the team values, their education, training, and also the learning with the environment that the service is being implemented in. So after this basic step in quality care comes the safe, the effective, the patient-centered, and the timely, efficient, and equitable care. All of these steps can ensure the best quality of care being presented to the patient. So, how do we know if we have provided the best quality of care to the patient? This will depend, of course, on the patient outcome. If we have resolved their complaint, which they came to the hospital with, using audit or complaint reports, using also staff survey with patient feedback to improve the quality of the care. So, what if something went wrong, which is possible in any healthcare facility? The first step is to collaborate with our team by sharing the concept with colleagues, building on the mistakes that were done to improve the care that is provided in the future. And the second step is to report the service issue that occurred, while the third step is to have feedback from the people who were involved in the situation. And the fourth step is to learn from the issue that occurred by, for example, presenting the new guidelines or educational seminars to avoid the occurrence of such issues in the future. And the sixth step is to amplify this by using the quality improvement systems, by exploring the options and engaging the patient and the healthcare staff to enhance and evaluate the level of the care that was presented. So there are different types of improvement that can be implemented in a healthcare facility. This can include, for example, in the research point to generate new knowledge and also scientific methods that are being used with the mainly clinical areas, but can also be in non-clinical areas, and also the processes of approval for funding and ethic approval. While for the audit improvement, this can be used as a standard for assurance, which can also be used to formalize the methodologies and best practice for data collection. And it can be based on any processes where there are clear standards, which can often have a planned annual program or mandatory audits for the quality assurance. And for the quality improvement, we can have a broader aims to improve in any area of the organization, with methods ranging from high programmatic to an in-depth statistical analysis research. So this is the model for improvement that we have explained previously. It can include what are we trying to accomplish, how will we know that the change is an improvement, and also what changes can make that will result in an improvement in the quality of care to the patient. So to make improvement, we need first to understand and investigate the situation by first identifying the situation and then diagnosing the situation by using tools such as process map, beginning to end that we have just explained. After the diagnosis, we should engage the staff, patient, and families as required. And the third step is the data drives for improvements, such as collecting the data that are simple or using quantitative or qualitative method, depending on the thing that we need to assess. And the last step is to make the change by using the SMART goal objectives that we explained previously. So as we mentioned, in any healthcare facility, adverse event can occur even if we implemented the highest quality of care, as these are sources of error that can be encountered by anyone. But we need to understand how to prevent it and prevent the adverse events and errors. So the dialogue around the medical errors only began to change in the past generation, and most dramatically in the late 1990s. So within the National Academic of Medicine report, it estimated that almost 44,000 to even 100,000 cases of American patients die each year from medical mistakes, which has generated tremendous public and media attention and set the stages for unprecedented effort to improve the patient safety. So these seminal works has built on a rich content of an equality and leadership in the field of patient safety. This led to small groups that devoted the generally unknown to mainstream the providers or the administrator and even the policymakers to make an improvement in order to prevent such errors in the future. So, according to this, the NAM death estimate, which was drawn from thousands of charts of about 200 reviews, this was followed by studies which showed that huge number of medication error, communication problems in the ICU, for example, with gaps in the discharge process, has retained, for example, the largest number of error, where everyone was looking for evidence of a major problem in the patient's safety. So accompanying this information in the professional literature, the scores of a dramatic report has laid in the media, including error of involving the wrong patient going to the procedure with surgery, for example, on a wrong limb, or chemotherapy overdose, or even a number of adverse events such as patient released from the emergency department to only die few hours later from a myocardial infarction. So the patient safety literature can contain many overlapping terms of described safety-related issues, and even though that the terms sometimes can confuse more than clarify, there are two key distinctions that underlie most of the terminology and allow us to keeping a relatively straight point of view. So the first one is that because the patient can commonly experience adverse outcomes, it is important to distinguish the adverse outcome as a result of a medical care from the morbidity and mortality of the patient's condition. So the former one are known as an adverse event or harm rather than an adverse effect. So these two terms are generally used interchangeably and have been defined by the Institute of Healthcare Improvement as the following. This is an unintended physical injury resulting from or contributed by medical care, including, for example, the absence of indicated medical treatment. This results in requiring additional monitoring, treatment, or hospitalization. The second term is that because patients can experience harm from their medical care in the absence of any errors, for example, from an accepted complication of surgery or medication side effect. So the patient safety literature can separate the preventable adverse event from the non-preventable one. So, the error or mistakes can occur in the safety literature that are commonly defined as error of an act of commission, doing something wrong to the patient, or the omission, failing to do the right thing to the patient, and leading to an undesirable outcome or significant potential for such an outcome. So we should also note that many errors don't result in an adverse event that generally characterize the more serious ones as a near miss or a close call. We should also note that some of the errors involved in the care that falls below the professional standard of care, which can be called as negligence and can even create legal ability or duty to compensate the patient some systems. So the process outcome or structure triad approach can see several advantages. The first one is focusing on adverse event, remove the implications that a specific provider was responsible for the harm, which may generate deafness by the caregiver or even an inordinate focus by the organization on dealing with the individual rather than the system. Also, patients can be quite naturally care more about what happened to them than whether their doctor or nurse can make a mistake. And even though that these advocates can make a valid argument, it is worth appreciating that the term preventable adverse event or a preventable harm are perhaps a bit too politically correct, where lacking the visceral punch of an error or a mistake, which has helped launch the safety field. And even one can be sure that vigorous debate, which has been with us since the early days of the field in healthcare, can continue. And for now, the patient safety center of the gravity remains on the adverse event or harm as the main focus of measurement and interventions. So these distinctions are important to understand as one tries to wade through the safety literature or even to interpret the individual cases. And to help illustrate the point, let's consider, for example, three scenarios involving a patient with a prosthetic joint infection who has been placed on appropriately prolonged course of intravenous vancomycin, but even still developed renal failure. So, if the renal dysfunction began while the patient's vancomycin level was being monitored at an appropriate level or intervals, and the level was felt to be in the therapeutic range, then this patient would be said to be the victim of an adverse event, which is often called a side effect when caused by medication. But it is not a preventable adverse event or a medical error. And in such case, this should promote us to reevaluate the benefit and the risk ratio of the intervention in this patient for specific, and also to try to improve the science, for example, identify a strategy with a comparable benefit to lower the patient's risk, but also not to interfere with that there was a mistake in the patient's care or that the harm was preventable because this was a simply side effect of the medication. While if, on the other hand, the patient developed renal failure because the vancomycin level was too high, but there was no overt error in the part of the physician fault, for example, if the physician was following the standard guidelines for dosing and monitoring, then the patient would be said to have suffered from a preventable adverse event. But in the case that this would still not be characterized as having been caused by an error. So also in this scenario, the patient can focus should be on reassessing the benefit to risk ratio and also the similar patient and improving the science to prevent this from occurring to other patients. And even though that it is worth considering to the system changes, such as more frequent monitoring, this still can have made a difference in this case and other patients like this one. And finally, in the third scenario, it would be a preventable adverse event and an error if the patient developed renal failure because the physician prescribed another antibiotic, which has increased the risk of nephrotoxicity in patients who were already on vancomycin without checking for any possible drug interaction. So, as we will see, rather than focusing on the failures of the individual caregiver, unless such carelessness is being habitual, then the more productive stance will likely be to consider the system changes with using, for example, computerized order systems with other robust decision support. This can help in preventing such errors and harm in the future. We should also add that some of the safety experts in Bristol add the distinction between the preventable and the non-preventable adverse event. This can remind us that certain types of harm can previously or were previously thought to be unpreventable, but are now being preventable with a better system. That is why we need to plan and review all the data we have in order to prevent the occurrence of such errors in the future. And for example, the strongest evidence comes from the argument of the story of the central line associated bloodstream infections, which were once felt to be an uninventable byproducts of the modern medicine, but are now known to be largely preventable with using consistent application or even a bundle of safety practice to prevent the development of infection to the patient. So the distinction between the preventability and the non-preventability parameters of the literature and also bearing with the risk to the public perceptions can result from errors which are yet to be defined. And as one point of reference, the studies of cases of harm in hospitalized patients were usually found to be about half and half that can be prevented in most of the cases. So even with this debate, it is likely to continue because the measurement is so fundamental to our effort to improve the safety with using reliable measurement, which is the cornerstone for conducting the sound research about the patient safety practice with prioritizing area of focus for study and implementation with holding individuals and institutions accountable for their performance. So over the recent years, the adverse event has remained stable despite any large-scale effort to improve the safety. And matters of the terminology and the measurement can seem arcane and only of marginal relevance to the patient or caregiver, but they are actually quite central to the field of patient safety. So we'll be taking a break now for a last of prayer, and then we will continue by discussing the challenges of measuring errors and safety to the patient care. Assalamu alaikum wa rahmatullah. Welcome back, everyone. We will continue by discussing the challenges of measuring errors and safety to the patients. So, incident reports can seem like a reliable way of tracking errors, but these are several problems with using them as a measure for the frequency of an error. First of all, even though that, for example, nurses tend to report errors through the incident reporting system, few of doctors do, which either don't report at all or even reporting through informal channels such as in teaching programs or telling the chief resident. And secondly, as most reporting systems are voluntary, the frequency of the reports will be influenced by the many factors other than the numbers of the errors. For example, let's say that the institution has improved its safety culture such that the reporting of error is now strongly encouraged by the local leaders and also the incident reports, which result in a tangible act. الصوت واضح عند الكل؟ تمام الله يديكم العافية. So, under these circumstances, an increase in the incident reports might well reflect on the same number or even fewer numbers of the errors that are simply being reported more diligently. So, in this case, this can distinguish the measuring patient safety from measuring the quality of the care, which is less dependent on the voluntary reporting and therefore can be done more reliably. While another method of measuring the safety is through a series of patient safety indicators that are generated from large administrative data sets. So the most widely used indicator set is the agency healthcare research for quality and also the patient safety indicator. Both of these comprise 26 outcomes or processes that are possible related to the safety, which are these indicators should only be used as clues for identifying the safety problems. نعم التسجيل مرة واحدة يكون. So even though that the AHRQ has cautioned that this can be inaccurate or doesn't correlate very well to the actual safety, these are increasingly becoming public reports which can carry financial consequence for hospitals and can also impact the hospital ranking, which is subject to the hospital and media security that cannot be wanted. So given the problem in using the incident reports and the administrative data to measure the frequency of errors or harm, there are other ways, which could be reviewing the chart for evidence of an error. While the chart review is also considered as an expensive method and labor intensive, so the burden may be eased somewhat by using an electronic medical record system, in particular if they can capture data in an organized way rather than as a pretext or if natural language processing improves. So the boost charting can also be on the same genes as the propensity of the comet's error, such as the penalization of the institution and the provider who will document well. And the meteorological climate almost certainly induces some of the buffing or the chart after an error occurs, with using chart review that is considered simply not a very reliable way to determine what errors has occurred. So in the chart, the problem is partially due to the inevitability of the Heysen bias, in which the knowledge of the final outcome can influence the reviewer's determination regarding whether a given act was an error or a problem that also because of many malpractice investigations. And over the past several years, the use of a trigger tools has emerged as a favored method to measuring the incidence of any adverse event in many healthcare settings. With the most popular of these is the global trigger tools, which was developed by the Institute of Healthcare Improvement with the premises behind trigger tools that is some errors in the care will even endanger the response that can be tracked. So, for example, if the patient with warfarin overdose can be given a dose of vitamin K, for example, or even a fresh frozen plasma to counteract the excessive anticoagulant effect, or if there was a patient who has received too much morphine, which can be treated with an opiate antagonist such as naloxone. Or even in the case of a patient who has an insufficiency of observation on the medical ward, which can be needed to transferred urgently to the ICU, while other events that are captured by the global trigger tools included these examples. So even though that trigger tools can identify the cases of medical errors, the incident of the reporting or even the administrative data can be based on the system miss or their overall effectiveness, which remains uncertain. While one study can or has demonstrated that reasonably good interrate reliability, and even a more study found that poor interactability with reliability, and even when using the global trigger tools to assess the patient safety, this was employed by even 5 teams across 5 hospitals with the same result. So, because many of the triggers don't represent an error or even a true harm, they are best used as a screen followed by more detailed chart review to more determine the source of the error or the outcome. The use of the global trigger tool currently can involve the significant labor cost that is largely for the follow-up chart review, but in some of this effort, it can eventually be automated assessment rather than person or labels. So it is also important to keep in mind that most of the literature on the trigger tools has focused on the hospital settings with using their outpatient ward that would need further studying. So several studies have utilized the IHI global trigger tools to assess the state of the patient safety. And according to study who tracked the rate of an adverse event in 9 hospitals in the USA between 2003 to 2008, has found that there is no significant improvement in the harm rate during these years, despite that major effort to improve the safety has been implemented. While another study in an US office of the Inspector General of the Department of Health and Human Services has found that 1 in every 8 medical care patients has experienced a significant adverse event during their hospitalization. And another study has found that approximately 1 in every 3 hospitalized patients can experience an adverse event of some kind, in which this study has compared the test characteristic of the global trigger tools with that of the voluntary incident reporting system and the AHRQ patient safety indicator, and found that the former, the AHRQ, was far more sensitive and specific to assessing any patient adverse effects. There are also two other assessment methods that are important. The first one was published in 2001 in the UK, which is the Hospital Standardized Mortality Ratio. This method has pioneered by the Professor Brian Jamin of Imperial College London, which generated significant enthusiasm in the improvement of patient care. So at a first glance to this method, a single risk-adjusted mortality statistics is intuitively appealing to roll up the measure, which seems to capture many aspects of the safety and the quality which can be trended over time. And in part, this is because of this natural appealing to the policymakers, which can be a major focus on the quality and also the safety errors in the UK and in the world, and the finding that higher HSMR triggered several hospital investigations to detect the source of the error and implement any new interventions as needed. And even with this method, it eventually criticized heavily due to the inadequate risk of adjustment method, as well as the low number of deaths that were thought to be truly preventable, but were actually not. And even in 2010, a study has found that four different popular methods of measuring the hospital mortality rate came to widely different conclusions about the hospital quality. So assessing the mortality rate is not as a reliable indicator for the quality of the patient care that is being delivered. Also, a recent trend has been to ask the patient themselves to identify instances of harm or error, as this tool is an appealing idea, but it can grow out of the border for movement to engage the patient themselves in their own safety and to respect their roles as an active participant in the care. So early studies has demonstrated that the patients are able to identify some errors that were missed by other assessment methods. And overall, the utility of this strategy, including whether placing a patient in this position or which can compromise their sense of trust in their caregiver. Therefore, it has not been yet fully defined or implemented. So, as we have seen, there are many ways to try to measure the number of errors and cases of harm to improve the patient safety, with the key point that is the frequency that will vary markedly depending on the method that is being used, and also on a robust institutional or even external program to assess the state of the patient's safety and also to learn from the errors and adverse events, which will need to be integrated several of these methods to have the best indicator of care. So, as you could probably have concluded from our discussion, the frequency of any error can be assessed as an integral part to assess the quality of the care that is being delivered to the patient. So, the impact of the errors is in part because of the different definitions and assessment methods, which various studies have shown that differing rates of adverse events can occur depending, of course, on the method that is being used to assess these errors. So overall, while early studies has identified adverse events in approximately 1 in every 10 admissions, recent studies has found that using the global trigger tool have found that the rates ranging from 1 to even 3 on the admission rate. And whether this change can represent a true increase in the harm or even a more sensitive measure is still unidentified. And interestingly, the overall hospital mortality rates have fallen markedly in the recent years, which can further highlight the safety measurements that are being indicated or implemented in the patient safety. So, in any case, given the substantial efforts that have gone into improving the safety over the past decade, the adverse event figures remain sobering, which should causes us to redouble our efforts and to make even sure that we are on the correct path to ensure the patient safety or the best level of patient care. And of course, not all of the adverse events are created in an equal basis, as we are more concerned about the adverse events that result in death or even disability than those that lead to an extra day in the hospital or even a delay in a test or medication intake. So, according to a study, is that some near misses cases in which this was not considered as harm at all, it can illustrate an important system problems and have a tremendous learning value for the organizational to improve their efforts in the future. And many safety studies using the National Coordinating Council for the Medicare Error Reporting and the Prevention Index for categorizing the errors, which can be graded for each error in a scale from A to I. So even though that about two-thirds of the adverse event courses has little or even no patient harm, about one-third do ranging from the minor harm such as prolonged hospitalization to even a permanent disability. So this risk is not evenly distributed across healthcare facilities, with some unfortunate patients that have or even a far higher chance of suffering from a significant adverse event. And as one can classic study demonstrate that these patients can often experience even multiple events of harm. So they estimated that the average patient in the ICU has about 1.7 errors in their care or stay at the ICU. And for example, it has been and considered the average hospitalization of the medical care patient to experience one per ICU day medication error every day of their stay. While patients on a multiple medications or even on a particular risky medication such as anticoagulants are considered more likely to be harmed as there are older patients who are more vulnerable to any error in their medical care. Also, the financial impact of the medical errors and adverse events is enormous, which can be used as a source to improve the care rather than to be wasted on errors to the patients. So, according to the NAM report, it was estimated that the overall national US cost of a preventable adverse event in the 1990s was between 17 billion to 30 billion. And as these numbers come exclusively from hospitalized or based studies, adding the impact of an adverse event in an ambulatory clinic or even nursing home would even double these costs. And when it is viewed in this way, it becomes difficult to argue that we cannot afford to fix the problem of the medical error. And historically, the widespread of fee-for-service payment system in the US and in the world have been part of this problem, as both the providers and the institutions have generally been compensated, often on the quite handsomely, for the unsafe care with even little financial incentive to make the required investment in a safe system. So the advent of an accountable care organizations and also the focus on a population health management or even caring for the patient across the continuum can shift the financial incentive in a way that can promote the providers and the institutions to invest in the safety. And even in countries and organizational structures that do the loss money from the error and harm, doing the accounting and determining the return of the investment from the spending on safety is very tricky to be implemented. And many recent policy initiatives are designed to increase the cost of the errors and the harm to system in an effort to promote the investment in the safety of the patient care. And even the largest impact of the medical errors and the adverse event can remain the toll that they take on the patient and also on their loved ones, which can be best measured in the anxiety, harm, and the death rate. So, in many cases, the providers are considered the second victim of an unsafe system that will let them down when they most need the support. And for all of these reasons, the moral and the ethical cases for the patient safety can remain the most powerful and motivator of all. So, as you know by now, there are a lot of tools or approaches to enhance the patient safety. And the modern approach to the patient safety is the system thinking and the Swiss cheese model for improving patient safety. So, historically, the approach to the medical error had been to blame the provider who delivered the care to the patient, which is the one acting at which that is sometimes called the sharp end of the care. For example, these can be the surgeons who are performing the transplant, the internists who are working up the patient's chest pain, or even the nurse that is hanging the intravenous medical bag. And over the last 2 decades, we have recognized that this approach overlooks the fact that most errors are committed unintentionally by hardworking, well trained individuals, and such errors are unlikely to be prevented by simply admonishing the people to be more careful, or even worse, by shaming or firing them. So, the current approach to the patient safety replaces the blame and shame game with systems of thinking with paradigms that acknowledge the human condition or the human errors and also conclude that the safety can depend on the system that is being created and anticipating of the errors with either preventing or catching them before they cause any harm. And while such an approach has long been the cornerstone of the safety improvement and in other high risk industries, the system thinking had been ignored and the medicine until more recent years. For example, a study or British researchers has created the Swiss cheese model of the organizational accident, which has been widely embraced as a mental model for the system safety. So this model is drawn from the accident investigations in the field, such as the commercial aviation and the nuclear power, which emphasizes that in complex organizations, a single sharp end, which is the person in the control of both, for example, in the nuclear plant, and the surgeon making the incisions. So errors is rarely enough to cause harm. So instead, such errors must penetrate multiple incomplete layers of the protections, which are the layer of the Swiss cheese, to cause a devastating result. And reasons for the model highlights the need for us to focus less on the goal of trying to have a perfect human behavior and suggest that the greater effort to be directed at the shrinking holes of the Swiss cheese, for example, can have the most probable impact on improving the patient safety. So the Swiss cheese model can emphasize that the analysis of the medical errors that need to be focusing on their root causes, not just the smoking gun, which is the sharp end error, but also all the underlying condition which made an error possible, or in some cases made it an inevitable error to occur. So several investigators have developed schemes for categorizing the root causes of an error. And the scheme can explicitly focus or even forces those reviewing the error to think about the contributing factors and to also ask the question, for example, whether there should be or have been a checklist or even a readback that is required for a particular process, and whether the resident was too fatigued or even to think clearly, or even whether the young nurse was too intimidated to speak up when she suspected an error has occurred. So, investigating all steps in the patient care will result in the best outcome for the patient safety. So, now we'll be discussing the differences between a slip versus a mistake. So even though that we are now understanding that the root cause of hundreds or even thousands of errors each year lies in the blunt end of the proximate cause, which is often an act of committing or even negligence or performed incorrectly by the provider. And even as we continue to embrace the system approaches as the most useful paradigm of that, it would be short sighted not to even tackle these human errors simultaneously. And after all, even a room filled with flammable gas, for example, will not explode unless someone strike a match. So it is not always the healthcare provider who should be blamed for an error. So when analyzing the human error, it is useful to distinguish the slips from mistakes. And to do so, one must appreciate the differences between the conscious behavior and also the automatic behavior. The conscious behavior is what we do when we pay attention to any task. And this is especially important when we are doing something new, like learning to play, for example, the piano for the first time. While on the other hand, the automatic behaviors are the things we do almost unconsciously. And while these tasks may have required a lot of thought initially when we have done them for the first time, after a while we do them virtually in our sleep. So humans can prefer the automatic behaviors because they take less energy and have a predictable outcome, and can allow us also to multitask, like, for example, drinking coffee while driving. But in some cases, some of the behaviors that feel automatic can require conscious thoughts. For example, when a doctor tries to write a routine prescription while simultaneously pondering the differential diagnosis for a challenging patient, which he is at risk of both for making an error in the routine automatic process of writing the prescription, which is defined as a slip, and also even in the conscious process of determining the diagnosis, which can be defined as a mistake. So slips are identified as inadvertent unconscious lapse in the performance of some automatic task as you absently drive, for example, from work every day from your house to your work, while the slips can occur most often when we put an activity on an autopilot, for example, so we can manage any new sensory input, which can be think through a problem or even dealing with fatigue or stress. So mistakes, on the other hand, can result from an incorrect choice rather than blundering into them while we are distracted, which we usually can make a mistake because of insufficient knowledge, lack of experience or training, or even due to inadequate information. So when measured on an error per an action, there are sick can have a conscious behavior that are more prone to mistakes than the automatic behavior, which are prone to slips. And even though that slips probably can represent the greater threat to the patient safety, because so much of what we as healthcare providers do is to act on an automatic base. So, healthcare providers are most likely to slip while doing something they have done correctly for 1,000 times. For example, asking the patient if they are allergic to any medication before making any prescription, and remembering to identify the patient identity before sending the patient to a procedure, or even, for example, giving them a medication. So the complexity of any healthcare works can add on to this task. For example, like any work that require a lot of attention, doctors and nurses are programmed to do many specific tasks under pressure with a high degree of accuracy. But unlike most of other professions, medical jobs typically combine three very different types of tasks. The first is lots of conscious behaviors with complex decisions and judgmental calls, with many patient interactions and also innumerable automatic behavior. So, the physician training in particular has traditionally emphasized that the highly cognitive aspect of any clinical practice has focused less on the human interaction and until recently has completely ignored the importance and the riskiness of any automatic behavior. And with all of this in mind, how then should we respond to this inevitable of slips? And historically, the typical response would have been to reimburn or even not fire the person who was in charge of giving the wrong medication, for example, because they need to be more careful next time, but by implementing small educational procedures or improvement in the same facility. And even if the nurse, for example, tried to be more careful, she would be just as likely to commit or a different error while automatically carrying out a different task. So, as the researcher has reminded us that errors are largely unintentional, it is very difficult for the management to control what two people, for example, didn't intend to do in the first place. And whatever the strategy that is employed to prevent the slips, a clear lesson is that boring or even repetitive tasks can be dangerous and are often performed better by the machines. So, in medicine, these tasks can include monitoring the patient oxygen level during a long surgery, suturing the large wound, folding the surgical retractors, for a long time and even scanning mountains of data for any significant pattern in the patient condition. For example, in the anesthesiologist research, they observed that people have no need to apologize for their failure to achieve a machine-like standard in those activities for which the machines are better suited, as they are good at other things such as original thoughts for one and empathy or even compassion for another. So it is true that people are distractible, but in fact, this provides a major survival advantage for them, as a machine designed to detect such event will continue with its repetitive task while the house, for example, burns down around it, where most humans will notice that something unexpected is going on and will change their activity immediately. For the general principles of the patient safety improvement strategies, these will be drawn on these mental models that the today patient safety field emphasizes the need to shore up the system to even prevent or catch errors rather than to create a proof individual provider or system. So, for examples, error in the routine behavior, the steps, can best be prevented by building in the readiness and the cross-check in the form of a checklist or even read back, and other standardized safety practice such as signing the surgical site before an operation or even asking the patient about their name before any medication administration. So these models also emphasize the need for standardizing and simplification of the care. For example, standardizing the process of taking the patient to the magnetic resonance imaging scanner, which can make it easier to bake on the correct safety procedures for each patient. And recently, there has been increased emphasis on decreasing the error at the person machine interface through the use of forcing function engineering solutions that would help in lowering the probability of a human error. And in healthcare, one famous forcing function was to change the, for example, gas nozzles and connectors so that the anesthesiologist could not make any mistake of hooking up the wrong gas to the patient. So, given the ever increasing complexity of a modern medicine, building in such forcing function in devices and technologies such as intravenous pumps, cardiac defibrillator, machine ventilators, and computerized order entry system is a crucial to the patient safety. So, in addition to the system's enhancement, there has been a growing recognition of the importance of improving the communication and teamwork. So, the term culture of safety is used as a shorthand to describe an environment in which any teamwork with clear communication and openness about the errors both to other healthcare professionals and to the patients are considered operative to the patient care process. So, another key to the patient safety principles is to learn from one mistakes. So, this may take multiple forms, such as the safe systems that have a culture in which the errors are openly discussed, often in the morbidity and mortality conferences. So there is a new push to make even sure that such discussions include members of that appropriate disciplines, such as nursing, for example, to point out the errors rather than the gloss over them, and in the name of avoiding any punitive atmospheres, and also to emphasize the system thinking and solutions to prevent such errors in the future. So, in addition to open discussions at conferences, a safety organization can build in mechanisms to hear about the errors from the frontline staff directly, often via incident reporting system or unit-based safety teams, and to also perform detailed root cause analysis of the major errors. And in an effort to define all of the layers of the Swiss cheese model that need attention before an error has occurred. So they also recognize the realities of any complex adaptive systems, such as overmanaging of the workers through bottles of top-down, the prescriptive rules, and the directive activity, which may be more unsafe than tailoring some degree of a flexibility and experimentations of to the frontline workers. While in the recent years, the organizations that excel in the learning from their experience are often described as learning healthcare systems. So finally, there is an increasing appreciations of the importance of a well-trained, well-staffed, and well-rested workforce in delivering a safe care. That there is now evidence linking that the low nurse to patient ratio, the long work hours, and the lack of board certificate to even poor patient outcome is catalyzing a more holistic view of the patient safety and recognizing that the implementation of a safer system will not create any safe patient care if the provider are overextended, poorly trained, or even under supervised. So, nor is the system thinking an excuse to allow for any caregiver or even their leaders to remain unaccountable for ailing to follow any appropriate and well vetted safety rules. So, this long list of potential approaches to the improvement of the safety can highlight one of the great challenges in the field, which is in the absence of any comparative evidence and in the light of the high cost of some of the interventions, for example, improved staffing, computerized order entry, or even in an organization committed to the safety, it can become very high or even overwhelming as they can consider which approach to emphasize on the patient care. While, on the other hand, because improving the culture is both difficult and hard to measure, its risk can begin to shuffle to the bottom, which is notwithstanding the importance to the patient safety. We will be taking a break now for 15 minutes and then we will continue with the quality discussion for the patient care. بإذن الله السلايدات كلها حيتم إرسالها لكم بعد نهاية الدورة مع المراجع. Assalamu alaikum wa rahmatullah. Welcome back, everyone. Now we'll continue our webinar by discussing the quality of patient safety. So, the definition of the quality according to the National Academy of Medicine is that the degree of which the health service for individuals and population can increase the likelihood of a desired healthcare outcome and that are consistent with the current professional knowledge. In 2001 report, the crossing of the quality champs, which is the NAM advanced of the 6 aims of the quality of the healthcare system, which are the patient safety, the centeredness of the care, the effectiveness, the efficiency, timeliness, and also the equity. So we should also note that this framework, despite the safety as one of these 6 components, in essence of making it substitute of quality. We should also note that even though that many clinicians tend to think of the quality as being synonymous with the delivery of the evidence-based care, then AIM can define which is more broader and include the matters that are of a particular importance to the patient, which is the patient-centeredness and timeliness of the care, and also to that of the society. And even though that the NAM make clear that the quality is more than the provision of care that is supported by science, evidence-based medicine does provide the foundation for much of the quality measurement and improvements. And in many decades, the particular practice styles of the senior clinicians or even prestigious medical center determined the standard of the care and also the variation in treatment approaches for the same conditions that was widespread. And without discounting the values of experience and mature clinical judgment, the modern paradigm for identifying the optimal practice has changed, which was driven by the explosion in the clinical research over the past 2 generations, which is the number of randomized clinical trials that has grown from less than 500 per year in the 1970s to almost 25,000 per year in 2015. So this research has helped in defining the best practice in many areas of medicine, ranging from preventative strategies for a 64-year-old woman with diabetes to the treatment of the patient with any acute myocardial infarction and even cardiogenic shocks. And the health services researcher, which is the Avidius Dampern of the taxonomy, is widely used as measurement of the quality of the care. The Dandy-Wedin triad can divide the quality measures into the structure, which is how the care is organized, the process of what was done, and the outcome, what happened to the patient themselves. So when used to assess the quality of care, each element of this framework has important advantages and also disadvantages, and the growth in the clinical research has established the link between the certain processes of care and also the improved health outcome because of this process that measure frequently, which has been used as proxies for the quality. So examples can include measuring whether a hospitalized patient with pneumonia received influenza and pneumococcal vaccinations, and also measuring the glucosylated hemoglobin A1C at an appropriate intervals in an outpatient with diabetes. And while there is still value in using processes measures to assess the quality in certain circumstances, the fields can focus on shifting toward the use of outcome measures such as a 30-day risk standardized mortality and a 30-day readmission rate. So the differences between processes and outcome measures is worth clarifying. And if the focus of measurement was on whether or not the physician has checked, for example, A1C level at an appropriate intervals, that measure would be considered as a classic process measure. While on the other hand, if the focus was on the actual value of the A1C, then that would be considered as an outcome, more specifically an intermediate outcome, that it is really a proxy for the outcome that we care about, which is, for example, mortality or kidney function or retinopathy, for example. And even though that such intermediate outcomes can seem like an attractive hybrid between the processes measures and the true outcome, it is important to clarify that the intermediate outcomes, like the true outcome measures, can require a case mix adjustment to fairly assess the quality of the care that is being delivered. And more importantly, the medical literature is rebuilt with cautionary report on the results of an intervention that improve the possibility of an intermediate outcome, such as the suppression of a premature ventricular contractions or even raising the level of HDL, but it had no effect or even increased risk of harm on the main outcome of interest, which is being measured. So where the science of the case mix adjustment is suitably advanced, for example, in the cardiac bypass surgery, a measure of the outcome such as the mortality rates are often used. And this is crucial because if there was a case mix adjustment, it is not well done, then the surgeon or the hospital that accept the sick patients can appear to be worse or even of the lesser surgeon or institution than that which can only take the easy cases or the mild cases. Furthermore, the case mix adjustment is often based on the administrative data, and if the care is not documented and coded adequately, then this adjustment would not be reliable reflection of the true severity of the illness. And finally, when the processes are quite complex and the science of the case adjustment is immature, then the structural measures are often used as a proxies for the quality. And as with the processes of measure, using a structural measure in this way can assume that good research has linked such element to the overall quality. And examples of such elements to the overall quality can include the structural measures that are supported by the strong evidence, including the presence or even a dedicated stroke service, nurse to patient ratio, and even a computerized provider order entry system. So it is worth highlighting that another special kind of outcome measure as we have seen with the NAM appropriate consideration of the patient experience to be one of the key dimensions of the quality of care. And accordingly, assessment of such experience can generally be collected through the patient satisfaction survey of administered after the hospitalization and the ambulatory visits, which have become important quality measures, both because of they can be reflective of an outcome which was intrinsically we care about, and because they may be associated with a higher quality of care. Also, the growing emphasis that is placed on the patient experience metric is reflected in the Affordable Care Act of 2002, which was established by the Medicare values that were based on purchasing the program or even the Pay for Performance initiative that financially rewards or even penalize the hospitals based on how well they do on a mix of processes and outcome measures. And in its first few years, the VBP placed a significant emphasis on the process measures, such as the administration of aspirin and beta blocker to patients who have myocardial infarction. And more recent versions of these indicators have focused more on the outcome measure, such as a 30-day risk-adjusted mortality of the patient, as well as the patient experience, the safety, the cost, and the efficiency of the service that was provided. According to Harvard Business School, the Professor Mitchell Porter argues that we should focus on our attention on the outcome measure as they are what matters to the patient. And the problems with using hospital mortality rate as a measure of the quality and the safety of the care has made clear that the validated processes measures are more useful for assessing the quality of care than the bad outcome of a particular measure. So, a good outcome measure doesn't obviate the need for processes and structural measurement that was implemented. For example, if we find that our readmission rate for heart failure patient or mortality rate for stroke admission are higher than that we would prefer, then the next step would be to examine our processes and the structure with comparing them to those of our peer or even those known as a best practice procedure. So this is what we mean when we say that one of the downsides of an outcome measure is that they are not directly actionable. And in the end, it is clear that a thoughtful mix of all of the elements of the donation triad process, the structure, and the outcome is all essential for developing a sound program of quality measurement and improvement. After understanding the quality of the patient care, we will now discuss the epidemiology of the quality problems. So, in a series of pioneering studies, according to a researcher, they have demonstrated large and clinically inevitable variation in the care from one city to another for the same problem or procedure. So, according to this study, the variation in the quality of the care for patients that was based on the race, the income, and gender was persistent. So these findings hint at a fundamental flaw in the modern medical practice. And after seeing such profound variation in the common processes and procedures, as well as in the outcome of a comparable patient group, we can only conclude that care is often inconsistent according to evidence. So this was stimulated by early studies on the disparities and the variation according to researchers which have more directly measured with the frequency which can clinical and healthcare organizations deliver the care that comport with the best evidence that is available. And according to another researcher that studied more than 400 evidence-based measures of the quality and found that practice was consistent with the evidence only in about 50% of the cases. And even though that adherence to the evidence-based processes can generally correlate with improved clinical outcomes, sustaining adherence after implementing the necessary changes in practice remain challenging. And even though that there are these largest differences between the best and the actual practice have caused patient providers and policymakers to seek methods to drive and support the quality improvement activities. It still needs more studying to be implemented correctly. So what are the catalysts for the quality improvement procedures? The problems that were described before have exposed several impediments of the reliable delivery of the high quality care. These can include the lack of information regarding the provider or the institutional facilities or performance, even though that this is changing with the growth of public reporting for certain metrics. Also, the weakness of incentive for QI quality improvement, and the difficulty for practicing the physicians to stay abreast of an evidence-based medicine, and until recently, the absence of system supports such as information technology for quality. And each will need to be addressed in order to make a sustainable gains in the quality of patient care. So the first step in the quality improvement began with the measurement. And initially, we were only had a handful of generally accepted quality measures, and most were focused on the processes of care, such as whether a patient with acute myocardial infarction received aspirin or beta blocker. While over time, the number of metrics with which the healthcare organizations are responsible for has grown rapidly, which has promoted by a variety of organizations, including the buyers such as Center for Medicine or Medical Services, as well as medical societies. And by the end of 2013, the CMS has developed more than 25 different measurement programs with over 800 discrete metric measures, which is a massive increase compared to that of 2006, when there was only 5 programs with 100 measures. And while these measures have identified many opportunities for improvement among the individual physicians, practices, or hospitals, the institution can face tremendous challenges in developing the infrastructure that is needed to actually measure and transmit the required data back to the CMS. And given the numerous amount of new literature that is published each year, no individual physician can possibly remain abreast of all of the evidence-based advances in any given field. And practice guidelines, such as those for the care of the community-acquired pneumonia, for example, or for deep venous thrombosis, aim to synthesize evidence that is based on practice into a set of summary recommendations that can be easily followed. And even though that some providers write the guidelines as the cookbook of medicine, there is an increasing agreement that the standardized best practice is ethically and clinically appropriate, and in fact, a high reliability of the organization hardwire such as practice whenever possible. بالنسبة للي بتسأل الأخت عن التبديل عادي مو مشكلة تقدري تبدلي لجهاز آخر. So as we were saying, the major challenges for guidelines developers are updating them as new knowledge accumulating and designing them so they can be easily implemented to the patient's care. Also, the clinical pathways are similar to the guidelines, but it attempts to articulate a series of steps that are usually temporary, or for example, on day one, and do the following, and on day two, do the following, and etc. So they are most useful for relatively straightforward and predictable processes, such as the post-operative management of patients after a cardiac bypass surgery or after a hip replacement. So over the years, the quality landscape has changed with some more remarkable changes than others. So even though that one could argue that professionalism should be sufficient as an incentive to provide high quality care, providing such care will depend on building a system to reliable translate research into practice, which can take significant investment in the developing of guidelines or physician education, for example, and more on. And historically, the buyers can be compensated by the physicians and hospitals with the same, regardless of whether or not the quality of care delivered was superb or even appealing, and providing that little incentive to make the requested investment to improve the quality of care. So this is changing rapidly with a blizzard of initiatives and metrics, including the B4B program, under which the provider and the healthcare organizations can have a quality support based on their quality services and catalyze the quality improvement activities. And virtually all involve several steps, which can include defining a reasonable quality measure, which include evidence-based measures that are capturing the appropriate structure, processes, or even outcome, and measuring the performance of a provider or a system with using these results to promote a change. And even though that each of these steps comes with its own challenges, the final one has probably created the greatest degree of uncertainty and has been the subject of the most experimentations. So the first step in the activities designed to promote quality improvement involves selecting appropriate measures, and for the local quality improvement activities, it may be fine to use process measures that seem possibly connected to an outcome of an interest, even if the evidence connecting the two is not bulletproof. And it is also often appropriate to use measures that are captured through the self-reporting by the involved provider while acknowledging the inherent bias in such data. And even though that we all aspire to perfect measurement, we don't let the perfect be the enemy of the good, as this is reasonable rule for many local QI projects. While on the other hand, it makes sense to insist on the higher standards for measures that are being used for the public reporting or the B4B program. And according to a researcher, they called these high stake assessment and accountability measures and proposed four criteria that they should meet for every step of the quality improvement. Also, the distinction of the more than academic interest researcher has shown that even if a provider checks a box of attesting that he or she would provide discharge counseling to the patient, for example, with heart failure, there is no correlation to the readmission rate. And this is probably because of the quality of such counseling and the individual patient comprehension, which can vary widely from one patient to another. Also, after the Medicare instituted a quality measure of assessing the timing of initial, for example, antibiotic administration for the patient with pneumonia, the 4-hour rule has subsequent studies which demonstrated that many emergency departments of the patients who were given an antibiotic were rushed by the physician later that proved that they don't have pneumonia or any infection at all. While another example included that even the post-operative venous thrombosis patient rates have been incorporated into several paid-for performance quality improvement initiatives. This can include the Medicare PPP program. The evidence has suggested that the measures can be flawed due to the surveillance bias, which the hospitals with a higher rate of VTE can simply spend more time and resources doing some unnecessary imaging. So it is clear that we have much to learn about which measure to the target can show how to collect the data and how to promote the improvement at a reasonable cost and with a minimum anticipated consequences. And once we settle on an appropriate measure, the next step involves promoting and supporting improvement, which can make it stick or even last. And even though that one might hope that clear feedback will generate a meaningful improvement in a provider performance, experience has shown that this strategy will lead to only modest change. And increasingly, a strategy directed at the transparency, which is the dissemination of the result of the quality measure to the key stakeholder, is becoming the norm. And with simple transparency, the hope is that the provider will find the public dissemination of their quality gaps to be sufficiently concerning to motivate for improvement. And furthermore, many can believe that patients or their proxies, such as a third-party buyers, for example, will begin to use such data to make choices about where the patient receive care. And up to date, even though there is little evidence that the patients are using such data to make the purchasing of the decisions, studies have shown impressive improvement in some policies that reported quality measures and supporting the premises that transparency itself may generate change overall. And according to a researcher, the framework found to be useful for considering the two interviewing pathways of selecting by the patient or the purchaser, and also changing or undertaking the provider organization through which the measurement is being provided. So increasingly, programs that tie the payment for the service to quality performance are being utilized to motivate for improvement. And even though the B4B program is conceptually attractive, it can raise a number of questions, which can include are the quality data accurate? Should the payment go to the best performance or to those with the greatest improvement potentiality? Also, another raised question is that do the existing measure adequately assess the quality in the patient with complex multi-system disease? And does the B4B program erode the professionalism or even create an undue focus on a measurable practice that is relative to an attention to the more important processes? Also, some can suggest that to make the real difference, these programs require a larger financial incentive and improved program design. And there are numerous B4B programs that are currently in existence. Those that are worth mentioning, the mixed evidence of the effectiveness is the emphasis of this program that is continuing to grow, especially at the individual physician level. And the Medicare can access the CHIP Reauthorization Act, which was passed by the Congress in 2015 and target the Medicare payment to the physicians. And combining several existing quality reporting programs into one framework, such as the physician quality reporting systems and the merit-based incentive of the payment systems, can all have a degree on the goal of tying the majority of the medical care payment to the value and increasing the amount of medical care payments that are associated with an alternative payment models. So while the details of this program are still being worked out by the time of this writing, it is clear that the pay for the performance is here to stay, and the physician will need to focus on building the infrastructure that is necessary to succeed of the undervalue of these programs. So after understanding the quality improvement programs, we need to understand the strategies to implement quality improvement. Whether the motivation is ethical, embarrassment, or even economic, the next question is how to actually improve the quality of patient care. So there is no simple answer for this question, as most institutions and physicians with success in their area use a variation of plan, do, study, act cycle that are recognized that the quality improvement activity must be carefully planned and implemented, and that their impact need to be measured, and that the results of these activities need to be fed back into the system in a continuously iterative process to improve the quality of the patient care. So a number of more complex and sophisticated methods have been developed in this business of the quality improvement and the manufacturing with industries, and that has been adaptive to healthcare, often but not always successfully. These include the commonalization and the differences between the quality and the patient safety. And even though the patient safety is a subset of healthcare quality, it is important to appreciate that some subtle differences between the two areas, particularly when it comes to measuring the performance and the changing practice to systems. So, for example, if we had a 74-year-old man who was admitted to the hospital with severe substernal chest pain in the emergency department, an ECG had showed that the ST elevation pattern that is typical for a large anterior myocardial infarction. And in this hospital, which has a cardiac catheterization lab, the ST elevation and the myocardial infarction are managed with primary percutaneous coronary intervention. So there is a strong evidence linking the door to balloon time to the patient's ultimate outcome. And in this case, there is a delay in reaching the cardiologist on call, for example. When they finally arrive an hour later, then the cardiac catheterization lab is not prepared for the procedure, leading to more delay in the patient care. So, for example, the cardiologist in this case has ordered a metoprolol, which is a beta blocker, and the pharmacist is concerned about the dose of the order, which seems to be high, but the pharmacist is reluctant to make the attention of the doctor to this error. So the pharmacist fills the dose, and that was ordered by the doctor. And luckily, the mistake is then recognized by the ED nurse, who questions the doctor about the correct dose on the administration. So the higher dose could have dropped the patient's blood pressure to the dangerous level. And after that, the higher dose could have ultimately led to the patient mortality. And as a result of the delay, the door to the balloon time is 150 minutes, with well above the established standards of the care, that is 90 minutes or less. So the patient survives, but the patient is left with moderate amount of heart damage and symptomatic heart failure. So this case can illustrate both the quality and the safety problems, placing the order on the wrong dose of medication that is clearly considered an error. And approaches to the prevention, such as error, include computerization, standardization of the common dose, and also changing the culture to ensure that the pharmacists would have probably called the physicians to clarify them for their mistake. But the prolonged door to balloon time also can represent quality problems of a failure in the process of care. Also, there was no overt error in this process, so it just took far longer than it should have been because of the lack of the coordination, the planning, and the training between the medical team. So, according to this example, the differentiation of the quality and the safety problem is important as we consider their causes and how to best prevent them in the future. For example, let's assume that the patient in this case ensures that was interested in measuring the quality and the safety of care in this hospital. So it would be relatively easy to implement a transparent, auditable process to document the door to balloon time and whether this patient has received the required medication at the time of their admission to the ER. And turning to the outcome of this patient, it would be straightforward to figure out whether this patient and similar patient were alive or dead at the time of the discharge and whether the appropriate intervention was implemented immediately. So the public reporting of the door to balloon time perhaps can be accompanied by a higher reimbursement for a better performance that would likely spur the improvement in the performance. So it is difficult to imagine a transparent, auditable, and efficient system that doesn't depend on the self reporting by the nurse, the pharmacist, or the doctor in this case. Also, a strategy of the public reporting for the medication error might leave the provider reluctant to report them, causing the system to be unaware that such errors were occurring and that ill prepared to the generation that shares the knowledge as well as the money and will to fix these problems. So the processes of fixing both problems, the door to balloon time, and also the medication errors can be relatively similar. And both are likely to require changes in the core processes with thoughtful implementation of technology, perhaps with an automated ECG reader for chest pain, for example, and changing the culture of reporting any errors and accepting any comments from any healthcare provider. So the bottom line is that patients have the right to expect the care that is both of high quality and safe, and the IOM, which is in AM now, can report on the medical error with errors of the human development that catalyze the national push to even improve the patient safety, which has led to important changes in the culture of training, regulation, and also technology of the patient safety. So even because of the measurement of the safety tends to depend often on the provider reporting and the retrospective chart review, the twin strategy of transparency and differential payments are more likely to improve the quality than that of the safety. Therefore, the two endeavors have enough compatibilities that need to be improving the information system that the quality improvement initiative will often result in a better safety if these were implemented appropriately. So, other cornerstones of the patient safety, such as the creation of a safety culture, can be largely independent on the quality improvement efforts and will often require a distinct focus. And all of these quality and safety improvement activities are relevant to the increasingly important work of removing the waste and the unnecessary cost from our healthcare system. So, the values that concern the quality improvement and the safety to the cost of the care. So, outside the world of healthcare, we can base most of our purchasing decision on our perception of the value. For example, who among us is always will need to buy the best thing that has the best value? So much of the focus of our lives can concern on the spend of trying to determine the value of the things that we are considering of buying. So we should expect also this with the provision of healthcare, as we should always aim to receive the best level of care that has the best amount of payments. So, healthcare decisions have traditionally not been made over this way, and partially because of the limited ability of the patients and their physicians to make rational judgment about the quality of a given doctor, for example, hospital, or even because of the function of the healthcare insurance that shield the patient from shouldering the full cost of their purchasing decision. Therefore, in other words, when we are buying, for example, coffee, we are allowed to be aware of the price of the service or the coffee that we are purchasing. The same should apply in healthcare, but this is often covered or the patient is responsible for only part of the payment if the patient has insurance. So much of the decade long revolution in the quality measurement and reporting can be seen as an effort to provide the patients or even the other interesting party with the information that need to make the rational decision about their healthcare value. Therefore, this framework becomes even more important as the cost of the healthcare continues to rise, crowding out the resources for other worthwhile private and public pursuits. So, increasingly, the efforts to improve the quality, safety, and the patient satisfactions are not taking place in a cost agentic vacuum, and rather the healthcare provider and organizations will be pushed relentlessly to improve both the numerator and the denominators of the value equations. Therefore, in this environment, we can already see the insensitivity of shifting from promoting the best care to promoting the best care at the lowest cost. So, in both the medical care value based purchasing and the no pay for error initiative, anything but perfect performance will lead to the reimbursement of the costs that were rather than the additional payment for the top performance. Therefore, the proportion of the payment tied to some type of the B4B initiative for both the hospital and the individual physicians will undoubtedly continue to increase in the recent years. We will be taking a break now for the Maghrib prayer, and then we will continue with discussing the basic concepts, term, and epidemiology of patient safety. Assalamu alaikum wa rahmatullah. Welcome back, everyone. We will continue our course with discussing the basic concept, terms, and epidemiology of patient safety and the quality of their care. So, first of all, in 1995, a middle-aged man named Roman went to see his physician in the US for chest pain. The physician suspected an angina and prescribed a medication in addition to ordering further testing. And despite the advent of electronic prescription, millions of prescriptions each year, particularly in the ambulatory setting in the 1950s, were still handwritten. So the handwriting prescription were the norm and the major source of medical errors back in the day. And the physician actually intended to prescribe a 120 tablet of a medication for the patient with a 20 milligram dosing. But instead of this, the pharmacist read the prescription, which instructed the patient to take 20 milligram pill every 6 hours. And unfortunately, the usual starting dose of the blindenyl is 10 milligram, making this an 8-fold overdose of the medication. And a day later, the patient's blood pressure dropped to a critically low level, leading to heart failure and eventually death within 1 week, all due to error in the handwriting of the prescription. So the modern pharmaceutical armamentment of that represent one of the healthcare great advances with highly effective agents to treat any mitigated effect of the most common medical conditions, such as hypertension and etc., with taking carefully the benefit of these medications that outweigh their risk. This remains a concern even with the medication that are being prescribed to and taken correctly, even with using a machine or computerized based prescription. So the growth of the medications prescription that approximately about 60% of the adults that are taking some type of prescription has led to a huge increase in the complexity of the medication prescription and the administration process of such medications. So it has been estimated that at least 5% of the hospitalized patients experience an adverse drug event at some point during their stay in the hospital. Therefore, another 5 to even 10% can experience a potential adverse drug event, meaning that they nearly took the wrong medication or even the wrong dose, but they didn't, and often thanks to a last-minute catch or sheer of luck. An example of this is the 3 elderly patients who are particularly vulnerable. Almost half of all the nursing home residents are exposed to inappropriate medication intake due to medication intake or error. So the cost of preventable medication error in the US hospitals is estimated to be about 16 billion annually in 2010. So things are not even safer outside of the hospital because the patient can still take the wrong dose when they are at home. And one surveillance study has assessed or estimated that for emergency department visit occurred per 1,000 patients annually, over 25% of these cases were required for hospital admission due to some medication errors. And approximately about 4.5 million ambulatory visits occurred annually due to adverse drug events. So the cost of a preventable medication error in the ambulatory setting is significant, bumping the total cost of medication error to over 20 billion each year. And historically, mainly discussion about the medication error has focused on the famous illegibility of the physician handwriting, but also as a result of a rapid uptake of a computerized provider order entry and electronic prescription that was stimulated by the 2009 health informatic technology, a bad handwriting is becoming a less important source for medication error. So unfortunately, medication error remain distressingly common still with even the computerized prescription. And there are many steps along the medication prescription and administration pathway that are vulnerable to mistakes at any steps of the patient care. And not the only might the prescription itself be prone to errors such as wrong medication or wrong dose, but also the administration of the medication generally that is mistaken in the pharmacy that need the proper for monitoring, such as forgetting to check the electrolyte and the kidney function, and etc. All of these need to be adequately reviewed when prescribing any medication. In addition to this, the patient's ability to take the medication correctly, or the caregiver ability to administer the medication correctly, or even the patient's ability to take the medication at all, for that matter, are all considered as vulnerable to error in each step of the process. So in such complex system, a statistical law inevitably takes its all toll with about 50-step process in which each step is done correctly in about 99% of the times, with the chance that at least one error will occur in a staggering about 40 almost percent of the patients. For example, a patient who was called Sarah is a 70-year-old woman who had undergone a cardiac bypass surgery. And after a stormy operation course, she seemed to be on the road for recovery. However, on the morning of her planned transfer out of the ICU, she suffered from grand mal seizures. So this shocked her caregiver as she had no seizures history before and was not on any medication that are known to cause seizure threshold. Therefore, they drew some blood tests and emergently wheeled her to the CT scanner to rule out the possibility of a stroke or intracranial hemorrhage. And while she was in transit, the lab paged the doctor to report that this patient's serum glucose was undetectable. And despite their multiple infusion of glucose, she never recovered from her coma. So in the subsequent investigation, it was determined that her bedside tray in the ICU contained vials of both heparin and insulin, and the vials were of similar size and shape. Therefore, the nurse intended to flush their line infusion with heparin had advertently administered a fatal dose of insulin for tube flushing. So, as this case demonstrated, the mitigation of the problem of the medication error requires solutions that address the steps that are involved in both the prescription and the administration phases of all steps in the medication. So many of the solutions that have been increasingly adopted over the last decades are technological, while the role of the CBOE and the electronic prescription with computerized decision support are identified as a possible source for reducing the errors in the patient safety. So we will focus on the solutions that are more specific to the medication prescription and the administration process, such as standardizing or even the 5-right double check method until the dosing or the removal of the risky medication that is being implemented. So the possible strategies to decrease the medication errors can include the standardization and decreasing of the ambiguity. Another example of this is that in the 1994, a popular Boston Globe health communist was hospitalized for recruitment of breast cancer at a center for cancer therapy. So this patient experimental protocol called for her to receive an unusually high dose of cyclosporidide, which is followed by a bone marrow transplant. So the ordering of the physician wrote the prescription as the cyclospamide as 4 grams per SQ over 4 days, which intended that she would receive a total of 4 grams every M2 hours of the body surface area spread out for 4 days. Instead of that, the nurse gave the wrong dose on each 4 days before the procedure. So the patient has died within a month because of the poor implementation of the procedure. And the highly publicized death of this patient has helped in catalyzing the modern patient safety movement, supporting the case for computerized and decision support for all patients. And it is easy to envision how a computer system programmed with the chemotherapy protocol that either presented the correct dose as a default option to the ordering clinicians or as automatically alarmed when someone prescribed an out of range dose might have prevented the error that killed this patient and resulted in a better care for all patients. But this patient death has also underscored the need for a standardization process with general agreement on the invaluable ways of communicating certain medication orders that would be understandable to everyone involved in the patient care instead of just relying on a written order. So, for example, a hospital could mandate that all medication given over multiple days must have the daily dose written each day, or that high risk medication could only be ordered for 1 day at a time to ensure that the one who is ordering the medication can check the dose every day. And one source of ambiguity has been through the long-standing use of abbreviation for certain medication. As in 2004, the Joint Commission has prohibited hospitals from using a group of high-risk abbreviations, insisting that the full name of these medication and instructions such as morphine sulfate, not MS-04, and insulin 10 unit, not insulin 10U, has to be spelled out to avoid any misunderstanding in the written dose. And one of the advantages of the CBOE has been its ability to further standardize the nomenclature and markedly limit the use of abbreviation for risky medications. There is also the five rights of medication administration, as many advances in the medication safety have come from system changes such as automating and double check individual caregiver, which are responsible for doing what they can to ensure the safety of their patients. And one long-standing nursing principle is known as the five rights, which highlight the five checks that the nurse is expected to make before administering a medication to a patient. So some have argued for additional checks, including the right documentation, the right action that is being given for the correct indication, for example, and the right form, for example, oral versus intravenous, with the right response, such as the nurse should monitor the patient's response to the medication. So some can add still another steps to this check as the right of the patient to refuse a medication when they don't need it. And even though that these additional rights have not yet become standard practice, they can further illustrate the tremendous challenges of correct medication administration and also the limitation of human vigilance as a safety bulwark. So the double checks on the other high-risk industries, for example, have long been used as even triple checks to ensure that critical processes are executed correctly. While in the patient safety, for its part, has become a long way to relatively quickly implementations. So 15 years ago, the only process with the standardized and invaluable independent double checks in most of the hospitals was that of the blood administration, in which two nurses confirmed the ABO blood type before any transplant is being injected. While thankfully most hospitalized now have built-in double checks for chemotherapy and other high-risk medication. And even though when the double checks are required by policy, it is critical to ensure that they are truly independent and double checked. It is also very easy as natural in fact to double check everything as in a sense of a rubber stamp, thereby providing any false pressure or reassurance rather than true increased safety. And preventing the interruption and distraction can also be a strategy to decrease the medication errors. These can include as each step of the medication prescription, preparation, and even administration process is subject to error. Therefore, we should minimize distraction as much as possible. And while the automation has been introduced into every phase, the vast majority of the medication deliveries is still involving human in each of these steps or processes. And for example, even in a hospital with a computerized order entry, the physician will still need to decide on the medication and the dose, with the pharmacist that need to take the order and dispense the medication to the floor, or even the nurse that need to collect the correct medication from the dispenser or a dispensing machine to deliver it to the patient. Also, each step of this step is subject to the mistakes, and recent research has quantified the extent to which a distraction and interruption can increase the probability of errors occurring to the patient. In addition to this, most of the research has focused on the nursing portion of this action, even though that there is little reason to believe that prescribing physician or pharmacist are any less susceptible to the hazard interpretation of the distraction when writing a prescription. So, a one-time motion study of the nurses preparing and administering the medication has found an average of 1.2 interruption during every medication process. And in a memorable example, it took over 2 hours for a nurse to retrieve a one particular medication from storage device because the device forced the nurse to close all 25 drawers each time she wanted to retrieve one medication. And even the process of administering a high-risk medication such as chemotherapy is frequently interrupted when being administered. And in one study, every time a nurse was interrupted during the preparation and administration process, there was about 12% increase in the clinical error. And emerging evidence is demonstrating that decreasing or eliminating distraction and interruption can improve the medication safety. So, in one hospital, nurses were given a protected hour during which they were not be disturbed by the telephone calls or any pages. And while the study didn't isolate this particular intervention from the several others, it did find a significant decrease in the medication error. And another hospital has created a no interruption zones marked off by the red tape of the floor to indicate that a critical care nurse was not to be interrupted as she was administering a critical point to the patient. And the establishment of the no interruption zone was associated with 25 with reduction in both the interruption and the administration error that usually occur. And before we get even too excited about such intervention, it is worth heeding that cautionary note of a researcher who point out that certain interruptions are crucial to even the delivery of a higher quality and safety of the patient care. So they argue against the banning of the interruption outright as interventions that need to occur for the complexity of the health system. And this is an important argument to consider, as it is easy to see how certain strategies to eliminate the interruptions could lead to even unintended consequences and even squeeze the balloon harder for the time of the therapy. So, a systematic review in 2014 of the value of reducing the interruption during medication administration has found a weak evidence in support of this strategy. And obviously, one cure for interruption and distraction would be remove the human from the medication prescription and delivery process. And while the automation is likely to do that of some degree, people will remain active and necessary participation in the medication prescription and administration pathway for the foreseeable future, as this can make continued attention to and to innovation in these areas which are being essential. Another source for errors in the patient care is the unit dosing. And this can refer to the packaging of the medication in a ready-to-use unit that are already prepared in the pharmacy and then delivered to the clinical floor. The unit dosing was developed in the 1960s, replacing the old method in which the pharmacy sent a large bottles of pills or intravenous medication to the floor, expecting that the nurse would perform the mixing or the dispensing of such medications. And the studies have generally found that the unit dosing administration is associated with even fewer medication errors, and the practice has now become nearly in the American hospitals that is to be dispensed in the pharmacies. Also, many pharmacy systems now include an automatic dispensing machine, which are usually computerized and often linked to the centralized inventory control system and have been shown to reduce the errors that are associated with medication administration and provide a sound return to the investment of using computerized methods. Also, the removal of medication from certain settings can be a source of errors. As the most widely cited example of this strategy is the removal of the concentrated potassium from the patient care areas. And because of the lethality associated with IV potassium overdose, as when the intravenous potassium is used in cases of capital punishment, such as the removal seems like a good idea. And rather than having the nurse add the potassium to their intravenous solution on the floor, the new system depends on potassium being added to the intravenous bag by the pharmacist before pre-mixed bags are sent to the ward. So this approach is an example of a more general strategy that is called forcing function, the technical or the physical obstacles that are designed to decrease the probability of an error or in an in-error prone circumstances or environment. So forcing the function are designed to anticipate the common human errors and make harm from them as impossible by blocking either the error or its consequence from happening. And the most widely cited example of forcing a function was to re-engineering an automobile parking system in the 1980s. And it made it impossible to shift, for example, the car into reverse when the driver foot was on the brake. So the removal of the concentrated potassium from the clinical setting would seem to be such a forcing function as the example, and therefore a logical safety solution to be implemented. And even though that this seems as a simple strategy, it was best by unintended consequences, as many nurses found that it took too long for their intravenous drip to arrive from the pharmacy. And because potassium was still allowed in the ICU, it often needed to be given in emergency situation there. The floor nurse began filtering potassium from ICU stages and holding it to other ward, which has created a more severe issue. So the lesson from this experience is not that keeping dangerous medications such as potassium on the floor is a good idea, but rather that frontline workers are often thought apparently when fixing it get in the way of their perceived ability to do their job efficiently, which is a process known as workaround. Therefore, they would choose the easiest solutions to receive the medication they need. So the safety planners need to seek out such actual or potential workarounds through the focus groups and the observations of providing their daily work, at least on the creating an underground economy in an unsafe practice. Another possible source of errors is the use of the clinical pharmacist. As all of these strategies employed to try to decrease the medication error, the insertion of a clinical pharmacist into the medication prescription and administration process is one of the most powerful steps that we can take to ensure that the patient receive the required medication properly. And an example of this is a classic study in the clinical pharmacist who became part of an ICU team in an academic medical center. So they educated the physicians and trainees and routed with the teams and intervened when they saw a medication error in the making immediately before this was developed later to a higher degree. So the intervention resulted in a nearly threefold decrease in the frequency of adverse drug interventions, which reduced the potential harm and yielded a significant cost saving for most of the medication. Also, other studies has found the impressive reduction in the preventable adverse drug events and inappropriate medication use when the pharmacist has assisted with the medication reconciliation and the pharmacy technician were they integrated into the emergency department. And unfortunately, in the United States, the high cost and national shortage of pharmacists led to these strategies to be relatively unemployed. And meeting the challenges of the lookalike sound-alike medication can also present a highly risky part to be noticed when administering a medication. So even though that the Food Drug Administration tries during its drug approval process to minimize the possibility that a new medication name will be confused with an old one, with about 10,000 agents in the pharmacopoeia with some problems that are inventable. And among the most confusing example is the played hydromorphine and the antihypertensive hydrolyzation, and also the antidepressant clobramine and the fertility agent clofamine. So there are a number of strategies to help in minimizing the risk of confusing, including the user of a Tolman lettering for the suffix of the drug that are named with the same prefix, such as clofamine and the chloramine. So eradicating this problem entirely would require technological help, including a barcoding administered system and also computerized order entry with the decision of the support. An example of this is that one can imagine a system that would ask for each medication indications and ask if the indication was seizure, for example, and the chosen medication was Celebrex. In regard to the medication reconciliation, this has emphasized the medication safety when the patient is static and in an ICU bed or even on a medical floor, or the doctor is a visiting clinicians. So the greatest opportunity for error in this case is in the medication process itself. That is likely to come when the patients are transitioning from one setting to another and being admitted or discharged from the hospital, or even going from their primary care physician office to that of the specialist, or even transferring between the wards. So studies have shown that unintended medication discrepancies are common and can occur in a rate of in about 30% of the patients at the time of admission, and a similar percentage when they transfer from one hospital site to another, and in 14% of cases at the hospital discharge time. So medication reconciliation is the process of reviewing the patient's complete medication regimen on both ends of the care transition, and also in an effort to avoid the unintended inconsistencies in the medication intake. And while many physicians have for long asked their patient to bring their old medication to the clinic appointment, the medication reconciliation have become formalized, relatively recently. So the search for an optimal method of performing reconciliation has gained considerable attention in 2004 by the Institution of Healthcare Improvement, which included it among the recommended practice in their campaign. So the following year, the Joint Commission has named the medication reconciliation as one of its national patient safety goals. And while the medication reconciliation have great faith in the validity of the method for accomplishing it, it have varied widely, and the research on it has produced mixed results. So the method have included having a pharmacist to perform the entire process involving the patient themselves in their own reconciliation and embedding the process in the electronic system. While one study involving the pharmacist has demonstrated improved clinical outcome and reduction in the adverse drug events. And the subsequent randomized controlled trial has showed that about half of the adult patients who received a pharmacist-driven intervention involving the medication reconciliation at the time of hospital discharge still has experienced a clinically significant medication error. So this, of course, all depends on the patient compliance or understanding. Nonetheless, the literature has generally seemed to suggest that integrating the pharmacist into the medication process is helpful and may even be cost effective to prevent any adverse event. And while research is beginning to illustrate some of the best practice in the medication reconciliation, there is uncertainty about what really works and remains most successful studies to illustrate the beneficial effect on the potential adverse event that through can present a true harm to the patient. And two reviews of an inpatient medication reconciliation has concluded that even though the pharmacist-led intervention could mitigate the medication discrepancies and the potential adverse event, after discharge, the clinical impact of these discrepancies was small, and therefore the medication by itself may not significantly reduce the adverse event or even readmission. And many institutions have seen their medical reconciliation ineffective uh, because of all of the disagreement on the crucial issues such as whose job it is to perform the reconciliation. And in light of these uncertainty, the Joint Commission has gone back and forth on the medical reconciliation requirement. And the challenge of this step is to it vividly illustrate how difficult it is to implement even with relatively simple fixes in the high complex systems of care. While the conservative prescription, this is worth emphasizing on the final point of the strategies to decrease the medication's error. And one key is to minimize the medication error is to limit the use of medication to situations in which they are truly indicated, which mean when the potential benefits of the patient exceed the risk over the harm that will be implemented. And as one example of this principle is the elderly hospitalized patients who receive medication considered inappropriate, such as prolonged use of proton pump inhibitor or aspirin without any history of cardiovascular disease. These have a nearly twofold increase in their odds of having an adverse event during the hospitalization process. According to a researcher, they outlined a series of principles for conservative prescription, and they are all worth following to prevent any risk of adverse drug medications. So there are more than 20 million people who undergo surgery every year in the US alone. And historically, surgery was considered extremely dangerous, in part because of the risk associated with the surgery itself, and in part because of the risk of the anesthesia. And because of the safety of advances in both of these fields, the surgeries today are extremely safe, and even anesthesia-related deaths are very rare. And advances in surgery, anesthesia, and post-operative care have led to major declines in the surgical mortality rates. And as with the medication errors, in which the problems from the intervention are grouped under a broader term of adverse drug event, for example, these can include both errors and side effects, with some surgical complication that occur despite impeccable care, while others are caused by errors. So the surgeries can account for a relatively high percentage of both the adverse event and the preventable adverse events. And for example, one of the major chart review studies of adverse event has found that about 45% of all adverse events were in the surgical patients. And of these, about 17% resulted from negligence, and about 17% led to even permanent disability. And looking at another way, about 3% of the patients who underwent an operation, they suffered from an adverse event, and other half of these were considered as preventable adverse effects. While another systematic review has estimated that about 1 in every 20 surgery patients can experience a preventable adverse event, and most of which were related to the preoperative care of the patient. And in the field of surgery, it has always taken the safety extremely seriously. As in the early 20th century, according to a surgeon in the commitment that was among the first people in the healthcare to measure the complication of care and approach them in a scientific way to prevent them from developing. So this surgeon has the end result of hospital following every patient for evidence of an error in the treatment and in the disseminating of the result of this inquiry, which was both revolutionary and high controversial at its time. So nonetheless, in the 1920s, the American College of Surgeons began inspecting the hospital in an effort that this can help the Joint Commission prevent the complications to the patients. And another doctor, which is a pediatric surgeon, is largely responsible for bringing the issues of the patient safety to the form of the medical practice that is being implemented today. And despite these remarkable contributions, surgery, like the rest of the medicine, has traditionally approached the safety as a matter of individual excellence, which is a complication that was deemed to represent a personal failing on the part of the surgeon, and the shift in focus to the system improvement, which catalyzed the major advances in the surgical safety that we know it as today. We will be taking a break now for a Elisha prayer, and then we'll continue discussing our topic. Assalamu alaikum wa rahmatullah. Welcome back, everyone. We will continue our course with discussing the volume outcome relationship in having an adverse patient effect. So, beginning in the 1970s, a study that was conducted demonstrated a relationship between higher volumes and better outcomes for certain surgeries. And substantial literature has generally supported the conventional notion that when it comes to procedures, the practice can make it perfect. So the precise mechanism of this relationship has not been elucidated yet, but it seems to hold for both the volume of an individual operators, such as, for example, surgeon or the interventional cardiologist, and also the institution, where the hospital or the surgical center is the involved party. So even though that much of the volume outcome relationship probably owes to the fact that teams can take time to start learning or anticipate each other reactions and preference, there is also seemed to be a learning curve for the procedural competencies. So one of the best studied example is that of the laparoscopic cholecystectomy, which is a technique that is essentially replaced the more dangerous and costly open cholestomies in the early 90s. So as lab closely emerged as the preferred procedures for the gallbladder removal, tens of thousands of practicing surgeons needed to learn the procedures well after the completion of their formal training, providing an organic test of the volume outcome curve. So the findings were sobering, as one early study of the lap colostomy showed that injuries to the common bile duct had dropped to almost 20-fold once the surgeon had at least a dozen cases under their belts. And after that, the learning curve has flattened, but not by much, as the rate of the common bile duct injuries on the 30th case was still 10 times higher than the rate after 50 cases. So patients can be confident that the graduates of today's surgical residencies are well trained in the techniques of laparoscopy surgeries. But in the early days of the new procedures, the patient have no such reassurance, as this was considered as a high-risk procedure. A survey in the 1990s has found that only about 50% of 160 practicing surgeons who had participated in a 2-day practical course of laparoscopy felt that the workshop had left them adequately prepared to start performing the procedure. So there is still a 3/4 of these surgeons who reported that they implemented the new procedures immediately after returning to their practice. And obviously, part of the solution for the volume outcome and the learning curve conundrum lies in the development of an innovative training models, including the use of the medical simulations to ensure that the physicians have the adequate skills to perform such procedures. And in fact, one study has found that surgical residents who underwent simulation training until they reached a predefined level of proficiency were 1/3 as likely to commit technical errors during a laparoscopic colostomies as those who received a traditional training. In addition to this, some surgical and procedure specialists are now requiring a minimum volume for prevailing on board certification, and also a major coalition of buyers, such as groups that promote high volume centers, which is one of its safety standards under the banner of evidence-based hospital. So this is asking hospitals to report of their annual hospital and surgeon volume for the 10 volume sensitive surgeries to better inform the minimum hospital and also the surgeon on the volume of the standard. In addition, certain states or insurers are insisting on a minimum volume or channeling the patient to a higher volume providers, such as institutions that achieve a good outcome and have a high volume, which are sometimes dubbed centers of excellence. And even though that such policies appear attractive at first, they are not without their own risk. As first, the patient may not be anxious to travel long distance to receive a care from a high volume provider institution. And second, the volumes that are too high may actually compromise the quality by overtaxing the institution or the physicians themselves. And finally, many of the procedures being discussed, such as cardiac or transplant surgery, are relatively lucrative surgeries that can be performed in any institution. Also, losing them could threaten the economic viability of the low volume institutions, which often cross the subsides of the nonprofit services, such as trauma care, with profits from the well reimbursed surgeries. So, this is not to say that the challenging of the patient to a high volume or better, safer, higher quality institutions and practices is a mistake, but rather it is complex maneuver that require a thoughtful consideration of both the expected and the unprofessional consequences that can occur. And with all of these discussion regarding the safety system, it is important to remember that procedural skills is still mattering and an integral part of this step. And in a remarkable study published in 2013, a researcher has asked the bariatric surgeon to submit a videotape of one of their operations. And a panel of at least 10 peers has blinded to the identity of the surgeon and the patient outcome, reviewed each videotape, and rated the surgical techniques. So the rating varied tremendously, with some surgeons that deemed to have a stellar techniques, while others were judged by their mediocre care. And in an analysis to the blinded to the procedural techniques scores, the score were found to be highly correlated to a series of key surgical outcomes, including the mortality, the complications, infection, and the reoperational procedures. And in keeping with the practice make perfect theme, while the surgical skills was not related to the years of practice or even training, it was strongly related to the procedural volume that was taken by the surgeon themselves. Another integral part of the patient safety is the patient safety in an anesthesia during any surgery. So even though that it is often stated that the modern patient safety movement began in the late 1990s with the publication of the National Academy of Medicine Institution, the field of anesthesia is noteworthy as an exception in these circumstances. As anesthesia began focusing on the safety generation earlier on, and its success can hold lessons for the rest of the patient safety field. In the 1970s, a young engineer named Jeff Kober has worked at the anesthesia bioengineering unit in the US. And similar to this patient, 60 years before him, he was troubled by what he saw at these hospitals, as mistakes were common and even cover ups were the norm. And even worse, numerous procedures and processes appeared to be error prone in their design. For example, he noticed that turning the dial of a clockwise increased the dose of the amphetamine in some of the anesthesia machines and also decreased in other machines. And after delivering a lecture entitled The Anesthesia Machine, an accident waiting to happen, as he stated, began to analyze the procedures and the equipment from human factors, prescriptive using the techniques of the critical incident analysis. This was done to explore all the positive factors of a mistake that can develop during anesthesia. Around the same time of this intervention, anesthesiology was in the midst of the malpractice crisis that was characterized by acrimony and other researcher or insurance premiums, with them recognizing the possibility that there might be an error in the patterns, which embarked a detailed review of the settled malpractice cases for themes and lessons that are the closed cases analysis. And some of the common themes were identified, including poor machine design, lack of standardization, lack of policies and procedures, with even inadequate education in some of the cases. And even though that the research and the insight in this work and the close case analysis were crucial, improving the safety in practice would not be possible without the widespread engagement of the physicians, which can have a unique point of view in introducing any missed point of view on the researcher side. And luckily, so often it happens that the right person emerged at the right time with producing the presidency of the Society of the Anthology in the late 1980s. And he was motivated by the experience of their friend who died under anesthesia during a routine dental procedure. This surgeon was convinced of foundation that helped support the work to make the care safer, and he probably coined the term of patient safety back in the 1980s. So his work has been closely with professionals, healthcare provider, and industry group, which has helped propel the field of fair work, first by convincing the caregiver that the safety problem was real and that it was soluble with the right approach and design of an intervention. And the lessons from this safety movement are broadly applicable to the efforts that are directed at improving the overall patient safety in general. And first of all, the safety requires strong leadership characterized by commitment to openness and willingness to embrace the change. And second, the learning from past mistake is an essential part of the patient safety. And in the case of anesthesia, the closed case review has produced key insight into the cases or the procedures that were implemented. And even though that technology is not the complete answer to safety, it is an essential part of the solution. And in anesthesia, the thoughtful application of oximetry and the automated blood pressure monitoring has proven as a vital life-saving mechanism. And where applicable, the use of human factors or engineering and forcing function can markedly enhance the safety, especially in a machine related device that is being used. For example, changing the anesthesia tubing so that the incorrect gases could not be hooked up was a crucial step to the prevent of such errors, and this was far more effective maneuver than trying to educate or remind the anesthesiologist about the possibility of the mix-up. And finally, anesthesia found itself in the throes of the malpractice crisis, and simultaneously had grabbed the numbers of highly visible errors that were reported to the media and corrected them immediately. And also, sparks in like these are often necessary to disturb the interior of the denial that can determine many of the safety errors which are being encountered. So in the 1980s, the anesthesiologists who paid experiment rates in the malpractice insurance among the highest of the medical professions back in the 80s. And now that error causing patient harm are unusual in the field of anesthesia, the current malpractice premiums fall in the mid-range of all specialties as a good example of the business case for the safety of any procedure that was implemented. Another major source of errors is the wrong site or the wrong patient surgery. In the 1950s and the 1995, a 51-year-old diabetic man with severe peripheral vascular disease checked into the hospital in the US for amputation of gangrenous right leg. The admitting clerk mistakenly entered into the computer system that this patient was there for a lift below the knee amputation and alerted the floor nurse, which caused the error after seeing the video on the day of the operation room that was scheduled and corrected that mistake. So the nurse has made a handwritten correction to the printed schedule, but the computer schedule was not changed. So since this computer system was the source of the subsequent information, this was not delivered to the hospital or the surgeon. Therefore, the surgeon entered the OR with reading the wrong order and amputated the wrong leg. So this error was discovered partway through the surgery, which was too late to save the left leg. And of course, the gangrenous right leg still needed to be removed, and a few weeks later it was, leaving this man double amputated due to a handwritten mistake. So events like these are so egregious that they have been dubbed by the never event, meaning that they should never occur under any circumstances. Therefore, one of the highest, riskiest steps that need to be checked at all times. And who could possibly disagree with this point? As recent systematic review of surgical never events suggested that there is one wrong site surgery for every 100,000 surgical procedure. So studies are also considered as outpatient surgery, and non-surgical procedures have given a higher estimate for these ratios. In addition to this, a published review suggested that wrong site surgery in the head and the neck surgery is very common, with events in the otolaryngal procedures accounting for about 0.3% up to 5% of all of the wrong site surgeries. Where in the 2010, a surgeon had publicly disclosed performing the wrong surgical procedure on a patient hand in a prominent 33 medical journal. And when one hears of a wrong site or wrong patient procedure, it is difficult to resist the instinct to assign blame, usually to the operating surgeon. Therefore, yet we know there must be something more to blame than simply carelessness of a surgeon or a nurse. So the answer, as the usual, is the Swiss cheese model and the bad systems that need to be implemented. Therefore, appreciating this can make a clear need for multidimensional approaches that are aimed to preventing the inventable human slips from causing an irreversible harm to the patient. Where the Joint Commission has also promoted the use of the Universal Protocol to prevent the wrong site and the wrong patient surgery and procedure. So, in a sense, the protocol acknowledges that single solutions to these problems are destined to fail, and that robust fix depend on multiple overlapping layers of protection with several elements of the universal protocol that merit the further comment. And at a first glance, signing your site, which the surgeon marks the surgical site, are considered as a simple procedure to verify the correct site and would appear to be of a particularly strong solution to be implemented. But in the early history of the sign your site demonstrate that even a reasonable safety solution can fail without a strong standard policies and enforcement of the protocols. So in the mid of the 1990s, before the Joint Commission or the surgical professional societies entered the fray, a number of well-meaning orthopedic surgeons began to use marking to help ensure that they operate on the correct surgical site. But unfortunately, without any standardized approach, the result would have been nearly comical, as if it wasn't so scary, with some surgeon placing an X on the surgical site, which can mark the spot, while other place X on the opposite limb, as in "don't cut here." So this can also be a source of misunderstanding or confusion. And even though that there was no documented cases of a wrong site surgery resulting from this actually, the implementation of a standard rules was crucial. And even today, the effectiveness of the site marking can depend on its correct implementation, as we have also learned that straight that help prevent the lateral error and cannot be worked for other types of wrong site surgery, such as incorrect spinal level errors. Also, another key element in the universal protocols, which is timeout, during which the entire surgical team is supposed to huddle and briefly discuss and agree upon the patient name and the intended procedure to prevent the occurrence of any complications. So this can also seem like a robust safety solution, which a fail-safe step to ensure to catch any error that eludes before the protection or the occurrence of such cases. And yet we have come to recognize how dependent these steps is on having a culture of safety in which one of all of those involved in the caring process for the patient are comfortable in raising their own concern up to the authority or the guardian, depending, of course, on the situation that is being present. So, without any safe culture and good communication, the interventions such as timeout can be robotic and function with providing the illusion rather than the reality and the safety to express one's concern. And while the component of the universal protocol can make sense and likely lead to some improvement in the surgical safety, this is yet another example in which a more holistic approach, in one that respects the challenges of achieving a meaningful change within complex adaptive system, was needed. And over the past several years, it has been seen that a number of successful experiments which were embedded to the core processes, such as Sign Your Site, within the broader set of activities that were designed to create a culture of safety, encourage the communication, and also increase the situational awareness with focusing on all the members of the surgical teams and also on the task at hand. With the first of such effort was an 8-hospital international study that combined the use of the World Health Organization surgical safety checklist with a variety of other activities that were designed to improve the teamwork and communication skills. And while its result was about 50% decrease in death rate and complication at both the well and the poorly resourced hospitals were impressive, the study validity has been questioned in light of the before and after design, with the absence of controls for confounding variables and also the fact that the outcomes didn't correlate with the degree of compliance within the intervention itself. So, reassuringly, an even more comprehensive surgical safety intervention involving 11 distinctive checklists was applied by the caregivers along with the surgical continuum that was implemented at a 6 teaching hospital in the Netherlands. And patients at the participating hospital had about 30% fewer complications and a nearly 50% lower mortality rate than those at a control institution. And as in the seminal study of the Michigan ICU, in which a checklist based intervention resulted in a major decrease in the central line associated bloodstream infections, leading many people to focus on the checklist as a magic bullet. Both the WHO and the Netherlands study authors has emphasis on the importance of a culture change and teamwork as a key success factor. And in fact, the WHO investigator has subsequently demonstrated that improvement in the safety culture can correlate with the improved surgical outcomes. And a study of the implementation of the teamwork training, along with a checklist in about 70 Veteran Affairs hospitals, found a striking improvement in the surgical mortality, along with the evidence of a dose responsive curve. Also, a more recent study looking at the impact of the mandatory surgical safety checklist at about 100 hospitals in Canada didn't find any improvement in the mortality, the surgical complications, the readmission, or even the length of hospital stay. And commenting on the study by Dr. Lucia, who suggested that in order for the checklist to achieve the desired effect of the improved safety outcome, implementation, workflow, and also the local culture need to be carefully considered to implement such interventions. Also, another researcher found that the original WHO study has critiqued the Ontario study design, noting that it might not have been adequately powered and need further investigation before it can be implemented. While another study of the medical care patient undergoing surgery in the US also found no improvement with the use of the surgical checklist. So, one reason for the variable impact may have been elucidated by the English checklist study, which found that the implementation of practice varied widely between participants. And this literature can make it clear that the checklists are part of the answer, but they are not the only part. And because of the issues that were related to the checklist, teamwork and culture have become so central to the entire field of the patient safety to ensure adequate implementation of any procedure. Another major source of error affecting the patient's safety is the retained sponge and instruments. A review study of about 50 patients who had retained foreign bodies over a 16-year period found that roughly two-thirds were actual sponges or even bites of absorbent gauze designed to soak up the blood in an operative field. And while the remaining one-third of other surgical instruments were left in the patient's body. So this frequently corresponded to an overall retained sponge at a rate of about 1 in every 10,000 cases, which has worked out to be at least one case each year for a typical large hospital in the United States. So because the study drew its sample from a malpractice cases, the problem is undoubtedly more common than this published estimation. And in fact, a more recent study found a retained foreign object rate of about one patient per every 5,500 cases. So determining the actual incidence is made more challenging by the fact that an average retained surgical sponge is discovered every 7 years after the surgery. In addition, unlike many other safety problems, the retained sponge or instrument problem would seem to be preventable by the thoughtful implementation of a systematic machine solutions that can be implemented during surgeries. So in the 1940s, manufacturers can produce sponges with loops that were attached in a 2 inches metal ring. So the ring will then hang outside the operative field while the sponge were placed inside the field or the body part. So when the operation was over, the nurse would simply harvest the sponges by gathering the rings. That way, the trial of fishing hooks is pulled out of the water by reeling the line. So as this sounds as a clever idea to collect or encounter all of the left sponges, surgeon found that the ring system is unwieldy, and many simply cut the rings off with even a classic example of a routine rule violation. So by the 1960s, manufacturers tried another approach, which is producing surgical sponges with an embedded radiovacuum thread that meant to show up on an X-ray after any procedure. So, but obtaining this post-operative X-ray on every patient is impractical, and in most cases, this X-ray is done months later when the patient is experiencing a persistent post-operative pain and the doctor are trying to figure out what is the problem. So the lay people leaving the sponge or tool behind can seem like a practical boneheaded error until you remember that complex or emergency surgeries often require dozens or even hundreds of sponges or other instruments that are inserted and removed under considerable time pressure. So this is one reason of surgical teams that have long been used as a sponge, sharp, and instrument count. Therefore, the standard protocol requires 4 separate counts when the instruments are set up and the sponges are unpacked, or even when the surgery begins and the items are called for and used at the time of a closure and during an external suturing. But unfortunately, the chaotic and the pressured circumstances in most of the busy ORs and the frequent changes in the personnel coupled with the requirement of the nurses to admit or even to facilitate the earlier count can create a situation in which the count can fail or they can create a mistake. Therefore, in most of the starting findings, the researcher has found one-third of the retained sponges cases had not been subject to documented count, where two-thirds of the cases were. And in about half of the cases, there were actually multiple counts of documented to be in the argument. So this meant that every sponge and instrument was accounted for, despite the fact that one would turn up later rather than inconveniently in the patient abdomen. Therefore, the real lesson from all of this is that what initially appears to be a perfectly logistic safety practice can often turns out to be a highly flawed implemented practice. Also, because of the sponge count of any kind are inherently unreliable, some experts have recommended taking an X-ray every surgical site before the field is sutured to ensure that everything was removed. And even if an X-ray were free and the patient and the staff were willing to put up the procedure and the additional radiation exposure, then keeping anesthetized surgical patient on the table any longer than that strictly necessary is not without its own risk. Therefore, this would be considered as an impractical procedure. So, partially for this reason, a researcher has recommended that X-ray only can be presented in high-risk cases, as those involving emergency surgery, prolonged surgery, and surgery which require real-time change in the clinical strategy, and also surgeries on obese patients. And even this plan has its own gaps because of the markers that are subtle and can be overlooked on an X-ray, therefore impractical in all of the cases. And ultimately, the best solution to this case is the retained foreign object problem probably lies in creating new technique that can be implemented to improve the quality or the safety of the procedures that are being done to the patient. In addition to this, some companies have developed a barcoded sponges while others have embedded their sponges with radio frequency ID tags that can cause a detector to want or even beep when the surgeon waves it over the field before a closure. Even with all of these hypothesized steps to help in the process, there are still that have built-in automatic sponges counter resembling the tool booth coin machine, which can be loaded up and checked after every surgery. So even though the experience with these technologies is still limited, institutionalizing the utilization of them have reported positive results in some of the cases. And in a decision analytical model, both the barcoded sponge and the radiofrequency tagged sponges system can appear to be more cost effective than either the sponge counting or the programs of a universal or selective post procedure radiographs, which include barcoding that is less expensive with radio frequencies. So one study has showed that organizations implementing the RFID technology had fewer retained surgical sponges than those who didn't. And reassuringly, the cost saving with fewer X-ray or less OR time had made up for the expenses of the RIFD uh, technology or mechanism. So since the inception of these patient safety movement has emphasis on the medication errors, handoff errors, or even communication and teamwork errors, the healthcare associated infection and surgical errors, all of which areas are amenable to technologies such as computerized system or procedural such as double check or even creating policies such as sign your site procedure to ensure that every step is being followed correctly. And until recently, the diagnostic errors have been less well emphasized, in part because they are more difficult to measure and also to fix. Therefore, diagnostic errors were unimprovised from the very beginning of the patient safety movement and in the landmark Institute of the Medicine. So they reported that the term of medication error is mentioned about 70 times, while the phrase diagnostic error come up only twice. So this is considered since the diagnostic errors can be accounted for about 70% of the preventable error, as the Harvard Medical Practice Studies has found that about 100,000 cases yearly death from the medical mistake and can continue to account for the significant amount of the preventable harm to the patient which can be achieved. So a review of the malpractice claims data in the United States in the period of the 1980s up to 2010 has found that about 400,000 paid claims of the diagnostic error accounted for about one-third of the claims, and the highest amount of the total payments were due to this type of errors. While another estimate has suggested that diagnostic error affect about 12 million adult outpatients every year in the United States. And as the field of patient safety evolves, the mantra for addressing the problem of diagnostic error is now viewed as a critical patient safety issue that is growing in count. And in response, in 2015, the National Academy of Medicine released another landmark report entitled Improving the Diagnostic in Healthcare. This report has concluded that the vast majority of patients will experience a diagnostic error at some point in the time and can suggest that the greater collaboration among the stakeholders is required to mitigate these problems from occurring at all. So the report also emphasized on the need for accurate measurement of the diagnostic error and outlines the opportunities to improve the diagnostic processes and also to reduce the errors in the care. And at a first glance, the diagnostic errors would seem to be representative of the human fault and the viewer lapses in the cognition. And it is true in some of the cases, perhaps more than that of any other area in the patient safety. And the training and skills of the clinicians remains as of paramount importance during all steps of any procedure that is being implemented to the patient. However, in keeping with our modern understanding of the patient safety, there are some system fixes that can decrease the frequency and also the consequences of diagnostic mistakes. This will be discussed along the line with further conclusions. Assalamu alaikum wa rahmatullah. Welcome back, everyone. So, the missed myocardial infarction can be a major source of errors in the patient's safety. An example of this is the case of a 70-year-old African American woman with mild diabetes, high blood pressure, and also elevated cholesterol that presented to the emergency department after having 30 minutes of squeezing chest discomfort. So an ECG was quickly obtained, and the ER physician has studied the tracing and has seen some of the non-specific changes in the NS and the ST and the T segments, but were not entirely normal, but they were also not an elevation that are classic as symptoms for acute myocardial infarction. So on examination, she found a mild tachycardia, clear lungs, and mild tenderness over the lower part of the patient's sternum. She considered the latter discovery quite reassuring, as after all, the tenderness would be more characteristic of a musculoskeletal process than of a heart attack. But also, the doctor has ordered a troponin, which is a biomarker released by the damaged heart cell. The result came back mildly elevated, again, not in the range for a specific MI, but also not normal. The doctor has also made a diagnosis of a costochondritis, which is an inflammation of the sternum rib joint, and prescribed an anti-inflammatory agent and bed rest, and released the patient from the emergency department. The patient died later that night as a victim of an undiagnosed and treated myocardial infarction. So, as you can only guess which cognitive error has caused the doctor to release the patient from the ER, and perhaps because of this patient was a woman, the ER doctor underestimated her chances of having a heart attack, which is more common in males than in females. So the doctor almost certainly relied too heavily on the chest wall tenderness for her diagnosis, which is unusual but also unheard of in the cases of myocardial patients. She also has overemphasized on the lack of clear evidence on the ECG and the troponin test. And even though they were non-specific, both were clearly abnormal and therefore justified admitting this patient or placing her in an observational unit for the cardiac monitoring, as well as to repeat the ECG and these tests that were conducted. And perhaps the doctor was just exhausted after having a long day at work, therefore, this could have impacted her judgment on this case. So, as we know that this particular error of sending a patient home with heart attack is distressingly common and frequently lethal, but it can occur in most of the cases. And approximately about 1% of admission for acute myocardial infarction can represent a prior missed diagnosis. And because the missed MI is the best studied diagnostic error, we will use it to make several broader points about this error in the diagnosis for patients. So physicians were more likely to send the patient home despite the worrisome histories or even the abnormal data when the patients were in groups of traditionally who believed to be at a lower risk for myocardial infarction, such as younger patients under age 55 and women. Therefore, also the non-whites were most likely mistakenly sent home more often, raising the question of racial bias, conscious or even unconscious, among the caregivers. And in one particular sobering study, about 700 physicians were shown videotapes of actors playing patients with chest pain that could have been cardiac in etiology. In these cases, four actors, each speaking precisely the same script, appeared on the video: a white man, a white woman, a black man, and a black woman. Regardless of their own race and ethnicity, the physicians were far more likely to recommend cardiac catheterization for the white males than for the black females. Also, similar variation in the diagnostic and in the therapeutic practice have been seen elsewhere in medicine, catalyzing the effort to address these healthcare disparities depending on the race. And researchers found that physician-specific differences were also playing a part in this error. And for example, one study showed that senior physicians were significantly more likely than their younger colleagues to correctly hospitalize the chest pain patients than those with real MIS. And were the older physicians better at diagnostic? Perhaps not, but the older physicians were also more likely to hospitalize patients without heart attack. In other words, with experience came the risk aversion, therefore hospitalizing more patients. Also, another study had showed that the risk aversion was not simply a function of age. And about 119 physicians completed a questionnaire assessing their attitude toward risk. The doctors who appeared to be risk seekers, for example, those who like fast cars and skydiving, were about 4 times more likely to send 16 of the same chest pain patients home than that of the risk avoiders. Also, one could easily look at the cases such as the one mentioned previously for carelessness of the doctor, which is an erroneous misdiagnosis and a fatal mistake, but we cannot look at it for this way. So how can we improve our ability to diagnose the patients who came to the ER or to the outpatient clinic with consultations of symptoms finding and also risk factors that may yield ambiguous results but can also be life-threatening? Too often, without a systematic approach, the clinical decision to admit or even discharge the patient or even to provide a particular intervention or treatment is also based on the physician faulty reassuring, which is in turn may be traced back to poor training or even inadequate experience or personal or professional bias. Even with the physician's own tolerance for at risk, this cannot be indicated appropriately. So to improve the diagnostic reasoning, it is also sufficient to say that such computerized adjustments are likely to help the clinicians make better or more evidence-based decisions, but also not well for the foreseeable future, that is replacing the clinician's mind with the main diagnostic workhorse. Can our cognitive bias be overcome? Perhaps more than any areas in the clinical medicine when the misdiagnosed patient, we need to learn from our mistake and to deepen our understanding of any clinical reasoning before making a diagnosis. So, as with most errors, the answer will come through systematic thinking, but also it can be a better system for training physicians and also to avoid the common diagnostic speed bumps that are indicated. And as the Canadian safety expert and emergency medicine physician Pat Korsky puts it, a one quickly distinguished characteristic of those who make high quality decisions is that they can largely free themselves from the common pitfalls of which novices are vulnerable. So, in all disciplines of medicine, learning about the clinical pitfalls that have been identified by the discipline expert is of paramount. And this says, in effect, that here is a typical error that will be made in this discipline, and here is how to avoid it. And this can only be implemented after careful review of every procedure and ensuring that the correct intervention are being applied. And interestingly, in the case of the chest pain triage decision, a decision that early researchers hoped to perfect through a combination of electric decision support and a better appreciation of the diagnostic pitfalls. And most experts can conclude that the quest for diagnostic certainty is at futile. So, in a number of research studies, even the best algorithms could not reliably identify patients whose actual risk of MI was so low that it was safe to send them home, especially when the penalty for even occasional failure might be a tragic death and also a multi-million dollar lawsuit. So the real progress in chest pain triage has come not from the homing of or diagnostic ability, but rather from the developing way, usually involving the repeated cardiac biomarker test and also the pre-discharge stress test to rule out myocardial infarction, which is inexpensive over a reasonably short hours of observation that need to be implemented. So, in a sense, we have abandoned our quest for diagnostic perfection and accepted that instead of a more mundane task of managing our uncertainty, the safely by resolving it quickly and expensively can be implemented in most of the situations to avoid the occurrence of errors. And yet, the study has cited that earlier on, it can offer hope that the clinicians can have cognitive ability which can be improved by teaching trainees about the historic and providing the opportunities for reflective practice and giving the physician feedback about the diagnosis and they have got the right and the wrong, with also encouraging the practitioner in M&M and similar conferences in which diagnostic errors are discussed and reviewed accordingly. In addition, the Tower Bridge 12 tips on teaching avoidance of diagnostic error seems like a useful starting point for these educational efforts to be implemented correctly from the start. And in the light of the emerging popularity of checklists in other parts of the safety field, some authorities have even advocated the use of diagnostic checklists, both in the general checklist and also in the from both clinicians to collect the complete data and to engage in the metacognitions with specific ones that forces consideration of the don't miss diagnosis when faced with certain subgroups that have even symptoms or even signs such as chest pain or tachycardia. All of these has developed the patient-oriented checklist to help the patient become better stewards of their own health information and to also aid in the diagnosis process, which can improve the outcome of any health intervention. And the theory behind the diagnostic checklist emerged out of the cognitive psychology of the dual processes model of thinking and reassuring, which state that clinicians can engage in both type 1, which is the fast, reflective, and initiative, largely subconscious studies, and in type 2, which is the analytic, the slow, the deliberate, and the requiring focus and attention thinking process. Therefore, the checklist might help to prevent type 1 error by forcing the physician to slow down and to overcome their innate diagnostic overconfidence by looking at all steps or all approaches of the treatment process. And while this is an elegant model and appealing idea, a randomized trial has found that the use of the diagnostic checklist in the emergency room didn't improve the error rates of the occurrence of any issues that developed overall. And furthermore, the research to understand the full potential of such intervention is needed to have a better outcome in the patient care in general and also improving the patient safety and their risk. So the systematic communication and information flow can issue in the diagnostic error and be an important point to consider when assessing any patient. So while the discussion of those emphasized in the cognitive aspect of the diagnostic error, many of the such errors owes to the more classic systems problems such as poor communication and even inadequate information transfer. So according to a researcher, I usefully break in these problems down into the 5 domains, which is a provider-patient encounter, a diagnostic testing, a follow-up, provider-provider interaction, and a patient-specific factor, such as adherence, all can play a role in the treatment process and have an effect on the patient's safety. So these systems and informational problems are likely to be more easily addressed than the cognitive ones described earlier. For example, the electronically promoting clinicians to follow up on a laboratory test and X-ray should improve the diagnosis accuracy. Also, it should provide a better access to specialty consultation online, evidence-based resources, and up-to-date problem list that every physician needs to check before making a diagnosis. And one organization has successfully leveraged its electronic health record to proactively identify the patients who are at risk for diagnostic errors. A researcher have concluded that many ways that advances in the information system can help to prevent the diagnostic errors from developing. So the final topic that we'll be discussing today is the overdiagnosis, which can also be a major source of affecting the patient safety in the healthcare facilities. So most of the emphasis in the area of diagnostic error has been in the misdiagnosis or the wrong diagnosis. Another important consideration is the overdiagnosis. But there is also a problem with overdiagnosis as well as the detection of any abnormalities that will never cause symptoms or death during the patient's lifetime if it was left untreated. So this problem may be accelerating because of the growing availability of the highly sensitive diagnostic tests to identify the small lesions such as tumor, but also the partial vascular blockage, blood clots, and other lesions, whose clinical importance is still unknown, but it is important to affect the patient's life and recovery. And because doctors don't know which patients are overdiagnosed, a researcher who works has helped to put this issue in the patient safety map, as we tend to treat all of the issues, even the minor one, to ensure the patient's safety. For example, as we are diagnosing many more cases of prostate and breast cancer than in the past due to the widespread and the use of a highly sensitive PSA screening and mammographies, while it is still not certain that aggressive treatment of these early cancer is leading to improved overall outcome, it is undoubtedly leading to some cases of HAN that is being discovered. And similarly, the incidence of pulmonary embolism is rising, probably due to the remarkable ability of the computed tomography pulmonary angiography, that is, to find small and potentially clinically unimportant emboli that is detected earlier on than those in the past. Therefore, there is another issue at play as well in the overdiagnosis, as diagnoses that previously were largely unknown, restless leg syndrome, fibromyalgia, and low testosterone levels, for example, they became more commensable after the pharmaceutical companies with potentially effective treatment began to bescope the patient and even ask your doctor about them to ensure that every patient with the condition is being diagnosed and treated with the medication for their condition. So there is also a study that was conducted with this disease monoemerging, and it is likely that it adds to toll of the overdiagnosis and overtreatment of these medications. So in a perfect world, the patient would stay in one place and would be cared for by a single set of doctor and nurses. But this is not the case. So doctors and nurses work in shift, and one patient can see many doctors during their stay at the hospital. So to hand off the process of transferring a primary authority and responsibility for clinical care from one department or caregiver to an incoming one, and also the transitions are facts of medical life and can also be sources of error if not monitored carefully. So, as we learned when we played of the game of the telephone as kids, every handoff and transition come off with a potential for a voltage drop of information if this wasn't mentioned clearly at the first point. And while it is possible that a set of eyes or even circumstances can offer a new perspective that will benefit the patient, our purpose here is that to explore the optimistic scenarios, and in fact, the handoff and transitional errors are among the most common and consequential errors in the healthcare facilities that can develop. In 2003, the limitation in the residency duty hours and further tightening of these restrictions in 2011 has markedly increased the number of handoffs in the inpatient setting in the teaching hospital in the United States. And as a result, the last several years have seen a growing body of literature that focused on ways to mitigate the harm that has historically accompanied handoff of the care transition. And as healthcare is chock full of two kinds of transition and handoff, the first one are the patient related, and as the patient can move from one place to another within the healthcare system, either within the same building or even from one location to another. This can present a source of errors. So in the second, which are the provider related, which are often when uh, the patient are stationary and the switch is between the provider or the doctor from one shift to another. And in both of these kinds, the handoff are fraught with hazard. For example, one study found that about 12% of patients experience a preventable adverse event after hospital discharge, while most commonly the medication error has occurred. And part of the problem is that nearly half of all discharge patients have test results that are pending at discharge, and many of them, more than half about them in one study, fall through the crack before having this pending result be checked before their discharge. While in another study, researchers surveyed the medical and the surgical residents, most of whom cited inadequate sign out and non standard sign out practice as causing the patient harm, especially when these handoffs took place over the phone or even with frequent interruption, leading to disturbance in the transition of the care. In one multi-center study, it demonstrated that the implementation of a standardized handoff bundle across 9 residency programs resulted in 23% decrease in the medical errors and in about 30% decrease in the preventable adverse event from developing. And further supporting the importance of standardization, a prospective cohort study found that the use of a web-based handover tools led to a statistically significant decrease in the medical errors, especially for those that were caused by failure in the communication and also inadequate handoff procedure that were implemented. And even if we grant that some transitions are necessary, one might reasonably ask whether the healthcare needs to have quite so many of them. But the answer for this question is that they probably do. In addition to this, research has demonstrated that patients appear to suffer more harm when their nurses work in shifts longer than that of 10 hours as compared to those whose nurses are working in 8 to 9 hour shifts. So, overexhaustion of the healthcare practitioner can lead to errors in the patient care or the patient service. So the issue may be more complicated than the shift length alone, as this can mean that they will be overworked or even depending on the number of patients that they are observing, depending, of course, on the unit in which they work in. And even though that one classic study had showed that intensive care unit residents can make fewer errors when they work in shift averaging of 16 hours instead of the traditional 30 to 36 hours. So all of this depends on the hours that is being worked, as having overworked healthcare practitioner will lead to reducing the level of care that the patient receives. While a more recent study of surgical residents showed improved satisfaction with the continuity of patient care and the handoffs in the group that didn't have to adhere to a strict limitation on the shift length and also the time off between the shifts, even though that both groups in the study were limited to the same number of the total hours per week. So this will depend, of course, on the time off between the shifts and also the number of patients they care about. And unfortunately, in about 24/7 hospitals, the shift limit and their associated handoffs are a necessity, depending, of course, on the number of the available staff and their workload or their capacity. And although that some might wistfully long for the day when the family doctors cared for the patients in the office, the emergency room and the hospital, with even possibly the operating and the delivery room, as well as most of the patients, can now expect the care to be provided by a variety of physicians, such as an emergency room provider, a surgeon, and a hospitalist, depending, of course, on the site of care and the patient condition. And as these specialists become involved in the patient care, they can create transition and the need for accurate information transfer at all cases, regardless of the patient condition. So, to those a patient's clinical need, to escalate the level of care, such as transitioning from hospital floor to a step down unit or to the economist realist that often drive the de escalation of the hospital to the skilled nursing facility. In addition, the presence of all of these handoffs and the transition can make it critical to consider how information is passed between the provider and the places in the hospital, such as different wards or different units, depending, of course, on the setting of the hospital. The catalyzed in part by the mandated reduction in the resident work hours in the US, which began in 2003 with further restriction along the future, which mandated that residency program establish a formal curricula around handoff, which there has been far more attention paid to handoff in the recent year to ensure that such error in the patient safety can be avoided. Also, there is an increased pressure coming from the policy arenas as well to ensure that there is guidelines regarding the handoff of patients. And in 2006, the Joint Commission has issued the National Patient Safety Goals 2E, which required the healthcare organizations to implement a standardized approach to handoff of the communication, including an opportunity to ask and respond to questions being asked by the patients. Also spurred on by studies demonstrating staggeringly high 30-day readmission rate in the medical care patient of about 20% overall, nearly reaching 30% in patients who have heart failure. And the medical care began financially penalizing the hospitals with high readmission rates in 2012 in order to ensure that the patients receive the best level of care for them to avoid readmission or even having fatal mortality rates. So thank you for your time. I hope you enjoyed our lecture today. That will be all for today, and we will see you again tomorrow for discussing further regarding the patient safety. If you have any questions, please do send them on the chat so that we can start a discussion. الله يعافيكم بالتوفيق جميعا. العفو بالتوفيق. ايوه كده خلصنا اليوم، لو في اي استفسارات ارسلوها على الشات ونناقشها. الله يعافيكم. إن شاء الله بنهاية الدورة كل السلايدات والمراجع راح يتم إرسالها لكم.